request Dr. Saurabh Singhal sir to formally invite ma'am to the dais.
Thank you.
I would like to thank the principal and the dean of Subharti Medical, the vice principal of Subharti Medical College, Dr. Satyam Bharati, for gracing the event with this presence. Thank you, sir. Ensuring this, I would request Dr. Saurabh Singhal sir to invite the Deputy Medical Superintendent of Chhatrapati Shivaji Subharti Hospital, Dr. Krishna Mukti sir, whose constant motivation and enthusiasm has played a key role in organizing this conference. Following this, I would request Dr. SUMECON-2024 sir to persuade Dr. Abhay sir, the Pro Vice Chancellor of SBSU, to come up to the dais. Next up, I would request Dr. SUMECON-2024 sir to formally invite Brigadier H.S. Vinas sir, the MS, to come forward and give the plant in his opinion. Lastly, I would take the prestigious opportunity to thank all the heads of various departments for their attendance to this conference. On behalf of the Department of Medicine, I assure you that this will be a Next, I would extend an invitation to Dr. Saurabh Singhal sir to welcome the KPI senior officials, Dr. V.K. Bindra sir, the President of KPI Meerut, and Dr. N.K. Sharma sir, the Secretary of KPI Meerut chapter. Now I would like all the dignitaries present to come forward for the very auspicious lamp lighting ceremony and declare the SUMECON 2024 open. I would request Dr. V.K. Bindra sir and Dr. R.K. Anand sir to please come forward for the lamp lighting ceremony. Dr. Tumbi Singh Arya sir, if you kindly grace us with your presence onto the stage, sir. इनके लिए Next in line, I would like to invite the volunteers to recite Saraswati Vandana. These budding doctors of MBBS 2022. I would like to request Dr. Saurabh Singhal sir to formally invite the principal and dean sir, Dr. Pradeep Bharti Gupta sir for gracing the event with his presence. Next in line, I would like to invite the volunteers to recite Saraswati Vandana. These budding doctors of MBBS 2022 would be dedicating the prayer to Goddess Saraswati, who is revered as the goddess of knowledge, music, arts, wisdom, and learning in Hinduism. Thank you. Thank you, young doctors, for such a captivating recitation. I hope this version of Saraswati Vandana has touched everyone present. It was such an uplifting experience for me personally and could have definitely a positive effect on the atmosphere. Next up, I would like to request Dr. Atul Krishna sir to formally invite the senior physicians, Dr. S.P. Sondi sir and Dr. V.K. Bindra sir, with a shot.
नेक्स्ट आ गया आवाज से भी खराब हो गई वैसे आवाज तो आती है मगर वो है ना एम्बुलेंस पे क्या
हाँ वायरलेस था
एम्बुलेंस पे
ये वायरलेस लगा रखा है लाइट पे सोलर लगा लो तो
कौन सा हटा देता है सारा पे इकट्ठा कर देता है एक जगह
नहीं वायरलेस माइक के लिए तो मैंने
Next
बोला
up, I would like to request Dr. V.K. Bindra sir to kindly come forward for the felicitation. I would now like to request the very honorable and respected Dr. Atul Krishna sir to inspire and enlighten our audience with his life experiences and insights that would serve as an anchor for the young and practicing doctors alike. Over to you, sir.
आज हम जो भी हैं अपने सीनियर्स की वजह से हैं, तो मैं परंपरा को तोड़ते हुए किसी भी कार्यक्रम में परंपरा होती है कि सबसे पहले वो ऑनरेबल वाइस चांसलर को प्रिंसिपल साहब को संबोधित किया जाता है, लेकिन मैं समझता हूं कि जो आज हम लोग कुछ भी बन पाए हैं तो अपने सीनियर्स की वजह से बन पाए हैं, हमारे जो टीचर्स हैं उनकी तरफ से बन पाए। तो मैं सबसे पहले सम्माननीय डॉक्टर R.K. एरन साहब को प्रणाम करूंगा और उनका स्वागत करूंगा कि आज वो हमारे बीच में यहाँ पर उपस्थित हैं। मेरे ऑनरेबल वाइस चांसलर सर, रेस्पेक्टेड प्रिंसिपल सर, हमारे साथी डॉक्टर S.P. सोंदी साहब और मेरठ की जाने मानी हस्तियां डॉक्टर V.K. बिंद्रा साहब, डॉक्टर तनवीर सिंह आर्या और विभिन्न बड़े बड़े डॉक्टर P.K. गुप्ता साहब हमारे सामने बैठे हैं। मेडिकल कॉलेज के मेडिसिन डिपार्टमेंट के हेड ऑफ द डिपार्टमेंट डॉक्टर सौरभ सिंघल, मेडिकल कॉलेज के और विभिन्न फैकल्टीज के यहाँ पर जो लोग बैठे हैं, मेडिसिन डिपार्टमेंट के सभी शिक्षकगण, छात्रगण, CEO हमारी जो आगे लेके हम लोगों को चल रही हैं, डॉक्टर शल्या राज, डॉक्टर परवेज साहब और हमारे अस्पताल के डॉक्टर मिन्हास साहब, डॉक्टर कृष्णमूर्ति। आज इस विशेष अवसर पर जबकि डॉक्टर मुक्ति की स्मृति में हम लोगों ने यहाँ पर ये कॉन्फ्रेंस सुमिकॉन करके जो 2024 में आप लोगों ने आयोजित किया है, आज हम लोग यहाँ पर उसके साक्षी बनेंगे। डॉक्टर मुक्ति के लिए इससे बड़ा और ट्रिब्यूट कुछ नहीं हो सकता कि जिस फील्ड में वो थी और मुख्य रूप से वो एक चिकित्सक थी और बहुत अच्छी चिकित्सक थी, एक टीचर भी बहुत अच्छी थी और डॉक्टर भी बहुत अच्छी थी। तो आज की तारीख में जो गुण होते हैं ये बहुत आवश्यक है कि किसी भी टीचर में होने चाहिए, कि वो प्रोफेशनली बहुत साउंड हो और क्लिनिकल ओरिएंटेशन उसका बहुत अच्छा हो और उसके साथ साथ जो बच्चों को पढ़ाने की कला हो वो उसमें हो। सामान्यतः ये देखा जाता है कि लोगों में नहीं मिलते, ये सारे गुण उनमें थे। और इसके साथ साथ वो एक डिसिप्लिनेरियन थी, कुशल प्रशासक थी। मुझको याद है एक घटना कि एक हम लोगों से हमने डीएनबी शुरू की थी, तो डीएनबी में जो पहला कैंडिडेट बालिका थी वो एक आगरा में एक आईएएस ऑफिसर पोस्टेड थे, उनकी बेटी थी। तो वो उनके अंडर, डॉक्टर मुक्ति के अंडर डीएनबी की ट्रेनिंग के लिए यहाँ पर आई थी। तो एक दिन मेरे पास, मेरे मित्र भी थे, वो आईएएस ऑफिसर तो अपनी जगह थे लेकिन मेरे मित्र भी थे। उनका एक बार मेरे पास फोन आया कि डॉक्टर साहब मैं अपनी बेटी को विड्रॉ करना चाहता हूँ। तो मैंने कहा विड्रॉ कर लीजिए, आपकी इच्छा, लेकिन बात क्या है? बोले कि वहाँ पर एक डॉक्टर है, वो बहुत गड़बड़ डॉक्टर है। तो उनको नहीं पता था कि वो डॉक्टर कौन है। तो मैंने कहा आप बताइए कौन डॉक्टर है? बोले कि मैं मिल के बताऊंगा आपको। मैंने कहा मिल के बताइए। तो मेरे पास आए मिलने के लिए और आके उन्होंने कहा कि मेडिसिन में एक डॉक्टर मुक्ति भटनागर हैं और उनके अंडर वो पोस्टेड है और उन्होंने तो उसका जीना हराम कर रखा है बिल्कुल। मैंने कहा बात क्या हो गई? बोले कि अब आप समझ लीजिए कि कब आ रही हो, कब जा रही हो, कब छुट्टी नहीं ले सकती हो, कभी ये बताओ कभी वो बताओ। तो अब मैं उनसे, आप या तो उनके खिलाफ एक्शन लीजिए, उनको चेंज कर दीजिए। तो मैंने कहा भाई देखो मेरी हिम्मत तो है नहीं। तो मेरे बराबर वाले कमरे में डॉक्टर मुक्ति बैठती थी। मैंने कहा कि मैं आपको ये काम कर सकता हूँ कि मैं आपको उनसे मिलवा देता हूँ, आप अपनी, मैंने तब भी नहीं बताया कि वो कौन है, और आप उनसे मिल लीजिए और मिलकर अपनी ग्रीवेंसेस उनको बताइए, हो सकता है कि उनको आपकी बात समझ में आ जाए। तो वो गए वहाँ पर, मैंने उनका इंट्रोडक्शन, वहाँ पर पर्ची भेज दी कि ये आईएएस ऑफिसर हैं, इनकी इस बच्ची के फादर हैं, तो आप जाइए। वो थोड़ी देर बाद मेरे पास आए तो वर्चुअली वीपिंग स्टेज में थे। आईएएस ऑफिसर होने के बाद भी वो बोले कि आपने मुझे कहाँ भेज दिया, और उन्होंने तो मेरी बेटी को तो छोड़ो, उन्होंने तो मेरी क्लास लगा दी पूरी तरह, और उन्होंने कह दिया कि ले जाओ अपनी लड़की को, अभी लेके जाओ यहाँ से। मैंने कहा आप ऐसा करिए, अभी ऐसे जल्दबाजी में कोई डिसीजन नहीं लीजिए, ये मेरी पत्नी है। जब मैंने उनको ये बताया तो अरे तो आप उनको ये भी मेरी मदद नहीं करा सकते? मैंने कहा बिल्कुल नहीं मदद करा सकते, वो तो मेरी भी टीचर है, तो वो एक एज ए टीचर अपना फर्ज निभा रही हैं। खैर ये एक बात आई गई हो गई, तो बच्ची वहां पर पढ़ी। और रिकॉर्ड है हमारे यहाँ का कि डीएनबी में आप लोग तो जानते हैं कि जो पास परसेंटेज होती है कितनी कम होती है, एंड दैट गर्ल पास डीएनबी इन फर्स्ट अटेम्प्ट। और आज भी उसके बाद से तो ऐसे मुरीद हो गए कि हर साल वो मुझसे मिलने नहीं आते थे, हर तीज त्योहार पे मिलने आते थे, कि डॉक्टर मुक्ति से मिलने आते थे और उनको वास्तव में उनको धन्यवाद देते थे और कुछ ना कुछ उनके लिए गिफ्ट लेकर आते थे कि आपकी वजह से जो आपने उस लड़की में डिसिप्लिन पैदा किया, उस लड़की ने पहली बार में डीएनबी पास कर लिया। तो ये टीचर का एक गुण होता है। तो शी वाज सच ए वंडरफुल टीचर, नो कॉम्प्रोमाइजेज विद एजुकेशन, नो कॉम्प्रोमाइजेज विद डिसिप्लिन। तो एक ऐसे टीचर की याद में आप लोग ने यहाँ पर जो कॉन्फ्रेंस यहाँ पर की है, बहुत अच्छी बात है। मैं आप सब लोगों को बधाई देता हूँ। और इसमें हैंड्स ऑन कॉन्फ्रेंस भी, आपने हैंड्स ऑन वर्क करने के लिए भी लोगों को, जो डेलीगेट्स, उनको मौका मिलेगा। इसमें मेरी इच्छा यही है कि जो उनका स्टेचर था उस लेवल की कॉन्फ्रेंस होनी चाहिए इन ड्यू कोर्स ऑफ टाइम। मैं आपको ये विश्वास दिला सकता हूँ कि जब तक मैं हूँ और उसके बाद डॉक्टर शल्या, डॉक्टर कृष्ण मूर्ति, ये लोग पूरा इस बात का प्रयास करेंगे कि मैनेजमेंट की साइड से आप लोगों को पूरा इसमें सहयोग मिलेगा। और वास्तव में ये कम से कम नेशनल लेवल की तो होनी चाहिए, और अगर हो सके तो इन ड्यू कोर्स ऑफ टाइम इंटरनेशनल लेवल की भी आप इसको करें तो बहुत अच्छा होगा। और मैं इस अवसर पर, हमारे सबसे अच्छी बात यह है कि आज हमारे बीच में जो ओरेशन के लिए आए हैं डॉक्टर एसपी सोंधी साहब आए हैं। डॉक्टर एसपी सोंधी साहब का मेरा जो संबंध है वो आज का नहीं है, जब से हम 8वीं क्लास में थे, तो मेरे ख्याल से 8वीं क्लास से हम लोग साथ पढ़े, तो गवर्नमेंट कॉलेज में हम लोग साथ पढ़े, उसके बाद फिर मेडिकल कॉलेज में हम लोग साथ रहे। डॉक्टर सोंधी भी इज ए वंडरफुल टीचर, इज ए वंडरफुल पर्सन। मतलब जो मैं कह सकता हूँ कि जो डॉक्टर मुक्ति में जो क्वालिटीज थी, अगर मैं कहूँ कि वो सारी क्वालिटीज में अगर एक व्यक्ति में किसी में देखता हूँ तो डॉक्टर सोंधी साहब में मैं वो सारी क्वालिटीज देखता हूँ। और डॉक्टर सोंधी साहब हमारे मेडिकल कॉलेज से जुड़े रहे हैं, हमारे बच्चों को ट्रेन करते रहे हैं। मैं समझता हूँ आज के अवसर पर उनसे कोई बेहतर व्यक्ति डॉक्टर मुक्ति को रिप्रेजेंट करने के लिए नहीं हो सकता था, जो मेडिसिन और मेडिकल फील्ड में उनको रिप्रेजेंट करता। हमारे बीच में जैसे मैंने आपको सबसे पहले कहा था कि अभिवादन भी किया था डॉक्टर आर के एरन साहब। डॉक्टर आर के एरन साहब के जीवन की हर चीज से हमें कुछ सीखने को मिलता है। जो आज के यंग डॉक्टर्स यहाँ पर बैठे हैं, बडिंग डॉक्टर्स हैं, या मैं कहता हूँ जो मैच्योर भी हो गए, जो पूरे अपने शिद्दत के साथ अपनी प्रैक्टिस या प्रोफेशन भी कर रहे हैं, उनको भी डॉक्टर एरन के बारे में जरूर जानना चाहिए, उनके जीवन की हर चीज से। डॉक्टर एरन साहब हमारे, जब हमने सुभारती की तरफ से कैंप हम लोग लगाते थे, तो डॉक्टर सर हमारे साथ मेडिकल कैंप्स में भी जाते थे, इनके गांव में भी हम लोगों ने कैंप लगाया था। तो सेवा भाव क्या होता है, शराफत क्या होती है और कॉम्पिटेंस क्या होती है, वो अगर हम कोई कहीं से सीख सकते हैं तो डॉक्टर एरन साहब से सीख सकते हैं। जो हमारा सब, मेरे ख्याल से जो सबसे पहला हमारा ओरेशन हुआ था, उसमें सर ने ओरेशन दिया था। थैंक यू वेरी मच सर फॉर कमिंग टुडे ऑल्सो। मैं आप लोगों के बीच में बहुत ज्यादा समय नहीं लूंगा, लेकिन मैं एक बार पुनः यह विश्वास दिलाते हुए कि डॉक्टर मुक्ति के याद में जो जितना बड़ा कार्यक्रम आप लोग मेडिकल साइंस में भी कर सकते हैं, सोशल पॉइंट ऑफ व्यू से हम कुछ भी कर सकते हैं, मैं उसकी बात नहीं कर रहा। मैं चाहता हूँ कि मेडिकल लाइन में जितना भी बड़ा आप कार्यक्रम कर सकते हो वो आप उतना बड़ा कार्यक्रम करें और पूरा आपको सहयोग दिया जाएगा। इन्हीं शब्दों के साथ और आश्वासन के साथ मैं अपनी वाणी को विराम दूंगा और डॉक्टर मुक्ति को एक बार, वो जहां भी होंगी वो हमारी गाइडिंग फोर्स हैं और गाइड हमें हमेशा करती रहेंगी। एक हमको फीलिंग होती है, एक ऑरा होता है हर समय। मैं तो सच बता रहा हूँ आपको कि जब भी एक कठिन समय होता है और मुझे लगता है कि आई नीड सम हेल्प, तो मुझे ऐसा लगता है कि देयर इज समवन टू गाइड मी, समवन टू हेल्प मी। तो ऐसे एक महान शख्सियत के लिए जो हमेशा हमें गाइड करती रहेंगी, आप लोगों को पुनः धन्यवाद देते हुए कि आपने यहाँ पर उनकी याद में आना स्वीकार किया। जय हिंद।
Thank you, sir, for your kind words. Further, I would like to request the CEO of the Subharti University, Dr. Shailya Raj ma'am, to come forward and say a few words in the remembrance of the noble soul, that is Dr. Mukti Bhatnagar ma'am.
Jai Hind. Honorable dignitaries of today, Honorable Vice Chancellor, Principal Medical College, very good morning and a Jai Hind to you. As the CEO, I congratulate the organizing team and also thank all the doctors, all the delegates who are present here today in the memory, which in the national conference which has been organized in the memory of Sanghmata. However, मुझे क्योंकि बोलने के लिए बुलाया गया है और मैं कभी भी प्रैक्टिस स्पीच नहीं बोल पाती, so मैं दिल से ही बोलूंगी and I'm going to tell you something which obviously all of us miss her and इतने 3 साल है but still you know that strong that you can speak totally, but फिर भी so एक बार क्या हुआ कि मेरी मम्मी से लड़ाई हो गई because उन्होंने किसी और को बेटा कह दिया। I was very this thing कि क्या मैं आपकी बेटी हूँ, कृष्णा बेटा है, अवनी है, आप किसी और को कैसे बेटा कह सकती हैं? So she said, I have so many children and Dr. Saurabh Singhal and Dr. Satyam, ये मम्मी के सब adopted sons हैं. So I congratulate Dr. Saurabh that he's taken up on this. I can't see where he is, but he's taken up on this to take this forward. And she was that loving that इतना वो सिखाती थी सबको, इतना प्यार से अगर डांटती थी तो प्यार उसका डबल करती थी और उसी उतने ही प्यार से आज भी इस कॉन्फ्रेंस में everybody I think apart of course the organizing team takes up all the effort कि वो सबको बहुत प्यार से और उससे बुलाएं, लेकिन जो एक इस नेशनल कॉन्फ्रेंस के साथ नाम जुड़ा है संघमाता का, वो भी लोगों को फोर्स करता है टू बी प्रेजेंट हियर टुडे. And again, I will thank everybody, especially the people who've been organizing on having this conference, and many more years to it. Jai Hind.
I would like to request Dr. Saurabh Singhal sir to formally invite Dr. Rohit Ravindra sir with the planter.
फ्लक्चुएट होता है क्या बीच में?
Further, I would request Dr. Major G.K. Thapyal sir to come forward and say a few words. Sir.
Jai Hind, all honorable guests, Professor Dr. Reron, all the oration speaker, and Dr. Vindra, our honorable and respected founder, Dr. Tarun Krishna, Principal Medical College, Vice Principal Medical College, Chief Executive Officer, Dr. Rohit, Pro Vice Chancellor, and all invited guests and dear students. I really feel honored and privileged to speak on this occasion. An occasion is really auspicious. We are remembering our Sanghmata, Dr. Mukti Bhatnagar, on her 66th birthday. I have not seen her, I have not met her, but that is probably my misfortune. But when I joined Subharti, before joining Subharti, I studied about Subharti, whose concept the Subharti is, whose thought process this Subharti is, and whose spirit is within the Subharti. And I learned it is the spirit of Sanghmata, Mukti Bhatnagar. So when I joined first day, I decided before I sit on my chair, I will go and garland the picture of Sanghmata. And then, of course, Swami Vivekananda, on whose name the university stands. I congratulate the Department of Medicine for having organized this conference. And theme is the wonderful, the medical emergencies. I also congratulate them that this is being organized under the Sanghmata chair. And this is the biggest tribute to the Sanghmata. One thing I would like to, and what I have understood during this last 2 years, that Dr. Sanghmata Mukti Bhatnagar was not just a physician. She was a multifaceted personality. And in fact, there is a saying that one should become master of one, jack of all, or master of none. But I will say she was the master of all, whatever she did. She was a great painter. She was a great artist. She was a great performer. She was a great physician. She was overall a great human being, a passionate. So under this chair, I think on these qualities, and plus she herself was the integrated personality. So I think based on her personality, that how she was integrating all these qualities within one personality, this should be the purpose of our chair, how we integrate various skills and to become a perfect human being as she was. With those words, I wish all the best to the organizer for the successful of the conference. And thank you very much. Jai Hind.
Thank you, sir, for your kind, enlightening words. Next up, I would like to request Dr. Principal, sir, to come forward and say a few words.
वर्कआउट कर रहे हैं सर क्या डॉक्टर एरन वर्कआउट नॉट फेयर चलिए जाइए वो आइए मैं तब शुरू करूंगा जब आप लौट आओगे ऑनरेबल डिग्निटीज माय डियर फ्रेंड्स थैंक यू फॉर गिविंग द अपॉर्चुनिटी टू स्पीक ओवर हियर एक बात जो आपने उनके बारे में नहीं बताई है शी वाज ए वेरी ब्यूटीफुल पेंटर एंड आई रिमेंबर when Dr. Atul got injured seriously in Lokpriya, admitted, I went to see him and he told me, look, Pradeep, I have painted Krishna ji, but I will not ornament him. मैं उनका श्रृंगार नहीं करूंगी, मैं श्रृंगार तब करूंगी जब अतुल ठीक हो जाएंगे। ये शायद डॉक्टर साहब को भी नहीं पता होगा। तो मेरे उनके साथ संबंध कमल नर्सिंग होम से थे, लोकप्रिय, सुभारती डेंटल, सुभारती मेडिकल, सुभारती विश्वविद्यालय। अब मैं उनके पार्ट का एक हिस्सा हूँ जो मैं पहले था, लेकिन हम लोग हमेशा साथ रहे हैं। ये एक कॉन्फ्रेंस का ऑर्गेनाइजेशन है, एक बीज बोया गया है, शुरू में कम लोग आएंगे, लेकिन प्रयास अगर हम सतत करते रहेंगे तो आगे चीज बढ़ती रहेगी। हमारा काम एज ए डॉक्टर प्रयास करना है और फल तो हमें मिलेगा ही अगर हम सच्चे मन से प्रयास करें। मेरा यही कहना है कि आप प्रयास करते रहिए, हमारा मेडिकल कॉलेज हमेशा आपके साथ है और हम उन्नति की ओर अग्रसर हैं। मेरी शुभकामनाएं आपके साथ हैं। धन्यवाद।
I would like to solicit the participation of senior API officials, Dr. V.K. Bindra sir and Dr. R.K. Aryan sir, to serve as the chairperson for the oration by Dr. Sondhi sir.
इसको दे ये लगा नहीं है क्या अभी?
I would like to solicit the participation of senior API officials, Dr. V.K. Bindra sir. Dr. V.K. Bindra sir, can you please come forward?
अंदर लग रहा है
Uh, Dr. V.K. Bindra sir is an alumnus of LLRM Medical College. He did MBBS from LLRM Medical College, Meerut. He did his MD Medicine from LLRM Medical College, Meerut. Currently, he is the president of API Meerut chapter. He was a past chairman of ISCCM Meerut chapter. He is a past scientific secretary of IMA Meerut. He is an ex-head Department of Medicine at IDST Muradnagar. We welcome you, sir, for it. Next up, I would like to invite Dr. R.K. Arand sir. Dr. R.K. Arand sir is an organizing chairman of RSS DIUP-CON 2019 at Meerut. He was the president of IMA Meerut branch 2008 to 2009. He was a former secretary of Professor H.S. Mittal Foundation, the prestigious body engaged in promoting the cause of academics in medicine. He was a teaching faculty at LLRM Medical College, Meerut from 96. He was a teaching faculty at Subharti Medical College in 2002 to 2005. He was a faculty in the National API Conference for the last 5 years. He has conducted public health education programs on NDTV India 4 times over the last 2 years. He has received Meerut Ratna Award 1999. He's on the advisory board in Mankind Pharma from 2017 to till date. He is in the advisory board in USV Pharma from 2015 till date. He is the chairperson of the API Meerut branch 2009 to 2014. Welcome you, sir. Next up, I would like to request Dr. R.K. Arand sir to kindly come forward and introduce Dr. S.P. Sondhi sir, our speaker for the day.
A very good morning to everybody. First of all, I would like to thank my dear friend and a very old associate, Dr. Atul, for the love, affection, and the kind words he has expressed for me. I think I cannot reciprocate in the same spirit, but really I cherish the days when we were walking. I would say we need a little bit of, have to be nuts here to do those kinds of things, Atul, which we did in those days. Anyway, welcome all the dignitaries. To introduce Dr. Sondhi, I don't think I need a written format. And I didn't know that I had to introduce him. But if I really start introducing him, I think it will take away all the time that is assigned to the lecture. I will only say that if there has to be one person in which the perfection is personified, he will be Dr. Sondhi. Whatever Dr. Atul Krishna has said about him, if I don't think I can go beyond that, but my association with him at very different dimensions, as a colleague, as a friend, as I would say as a brother almost. It has been last, how many years? 37 years that we have been meeting once in a week, having dinner together, having discussed the academics, of course, on the pretext of doing academics, fighting with each other, loving each other, agreeing with each other, agree to disagree with each other, all those things which cannot be probably combined into single emotions. But for formal purposes, Dr. Sondi, as you all know, is one of the senior most physicians here. The standards which he has set in all sense of words in the medicine practice are unsurmountable. So with that words, and especially the subject that he has chosen for it, only a person like him can justify it. Because the science today, the facts, you don't study for the facts. They are available at your fingertips. You go to the Google and all the fund of knowledge is available there. But the hard-earned skills, which are so much needed in the medical practice as a doctor, in whichever specialty you are, they need a lot of time, lot of efforts, lot of hard work to do. And Dr. Sondi has mastered that art of diagnosis. So he would be probably, I would request the young crowd especially to learn those things which he is going to tell you and which are not available anywhere in any book or any site or anywhere, which only a person like him can teach you. And with that, I invite Dr. Sondi to please deliver his lecture.
Very chilly good morning to all of you. Dignitaries sitting in this hall, and my dear friend and my seniors. दो चीजें पहले ही करेक्ट करा दूं कि अतुल जी ने आज मुझे थोड़ा झटका दे दिया. अतुल जी ने यहाँ डायस पे आके ये कह दिया कि हम 8th स्टैंडर्ड से साथ पढ़े. तो मैं सोचने लगा कि मैं 6 से 8 तक किसके साथ पढ़ा. तो फिर मैंने याद दिलाया कि भाई हम 6 से पढ़े, हम 8 से नहीं पढ़े. सो वो करेक्शन है. एंड सेकेंडली आज याद आती है डॉक्टर मुक्ति की, बहुत याद आती है. मैं उनसे पर्सनली चाहे कम मिलता था, पढ़ाने आता था तो कभी मुलाकात ज्यादा नहीं होती थी, लेकिन टेलीफोन पे ऑलमोस्ट हर 10 दिन में 15 दिन में मेरी बात होती थी और डिटेल बात होती थी और शायद अतुल से ज्यादा बात होती थी. और मुझे उनकी पर्सनालिटी तब दिखती थी, समझ आती थी. मैं आज ये सोच रहा था कि डॉक्टर मुक्ति ने किस चीज में एक्सेल किया. Was she a better family person? Was she a better administrator? Was she a better performer? Was she a better teacher? Was she a better student? क्या चीज थी वो. लेकिन मुझे अल्टीमेट और कई लोगों को ये पता है that she will not mince word when she'll talk to you. She'll be very outspoken, but she will. उनको कोई फर्क नहीं पड़ता था, वो मुंह पे कह देती थी अगर आप में कोई कमी है. So ultimately, I think she was a wonderful human being. She had a purity of heart. She never meant ill towards you. Never, never, never. तो वो उनकी खासियत थी कि वो आपके मुंह पे बात कह देती थी, फिर भी आपको बुरा नहीं लगता था, बिकॉज आपको पता था कि she is pure at heart. She means well for you. And secondly, I think she was a wonderful leader. उन्होंने इतने, मैंने देखा है, I have seen progress of Dr. Saurabh. Dr. Saurabh और हमने डॉक्टर सौरभ ने मैं को-गाइड था उनकी थीसिस में. तो Dr. Saurabh has come so long way. He's matured so beautifully. He's outperformed himself because of guidance of Dr. Mukti. I think amazing. So I think वो emotional था और emotion में हिंदी आ जाती है, तो हिंदी में ही बोल सकते हैं emotion. अब English में बोल. Right. So today when I was told that I have to speak an oration, and I was searching my mind what should be it, and then I thought it should be art of diagnosis. We all are aware about the science of diagnosis, but it should be art of it. Can I change the slides from my side? Okay, you will do it. Okay. And please go to my first slide. So when I say art of diagnosis, I say how not jump to a conclusion. Most of the time we are jumping to conclusions, and I don't want that. Especially in a teaching hospital, I want everyone to be trained to reach a diagnosis, not jump to a conclusion. Next slide. And whenever we talk about teaching residents and everything, we remember Dr. William Osler, who was a Canadian physician, who for the first time started residency program for the medicine people. So he's almost, we think that he's the father of modern medicine. And he said, medicine is a science of uncertainty and an art of probability, which highlights that many times we are on a sticky wicket. We really don't know what we are treating, even with the best of our efforts. Next slide. So, but we all know that diagnosis is the crux of patient management. Unless we are able to diagnose, we will not be able to treat the patient at all. And we know, can you please put the little lights off here? All right. We know that there are two parts of diagnosis. One is the science of diagnosis. Other is an art of diagnosis. Next slide. Science is extremely important because unless we know the presentation of diseases, we will not be able to diagnose. No amount of art will suffice the science. The science has to be there. And I always remember this quotation from White's Pathology, which said that your eyes don't see what your mind doesn't know. If your mind doesn't know a sign or a symptom or whatever, it will be right in front of you, but you'll never be able to see it. So the science is very, very important. I'm not going to talk about the science because science is huge. There are chapters of different diseases in the books. Next slide. But I will talk a little bit about two parts of the science. One is history taking, another is examination. Just 2 slides, and then we'll go over to the art of diagnosis. About history taking, we all know that if we take the correct history, almost 70 to 80% of the time, we will reach a probable diagnosis. We will reach a hypothesis. But what is the problem? Next slide. The problem is this, that doctor is not ready to listen. In one of the studies, they found out that the first interference the doctor does in a history taking is 20 seconds. He does not allow the patient to talk about his first symptoms. And if he had not interfered, the patient would have finished his first sentence in 2.5 minutes. But he gives him only 20 seconds and then interrupts. It's almost like the patient has started saying, "Mujhe khansi hoti hai." Acha, balgam aata? हाँ, मुझे बलगम बलगम कैसा आता है? पीला आता है सफेद? You interrupt, and because you have no time. So next slide. Next. So can you imagine that in today's world, one study was done which was printed in BMJ, that if a doctor is on the round in the hospital, and if you put a chair very close to the patient in every room, and the doctor sits in that chair, just the very fact that the chair is available right beside the patient, and the doctor sits there and listens to the doctor, increases the patient's satisfaction rate. So just by giving time, just placing a chair near the patient's bed. Next slide. Physical examination, we have all been teaching examination of the heart, examination of the nervous system, and so on and so forth. I'm not going to go into details. We can't go into the details. But a couple of things about examination which are important. Next slide. That sometimes negative findings are as important as the positive ones. We must remember. Next slide. And sometimes the findings are there, slightly hidden. You have to find it out. Like if you look at the neck of this patient, you don't see anything. Can I have a pointer, please? Do you have a pointer? No. Okay. But if you just ask the patient to bend the neck, you see the telltale signs of acanthosis nigricans lying right there. So that means you have to search very unlikely places. You have to poke your finger in the axilla to find an axillary lymph node to diagnose PUO. So sometimes the findings are hidden, so you have to find them out. Next slide. Right. So this was about the science. Now I'm on art of medicine. So how do you think? How does your mind think as a doctor? Yeah. So our mind thinks like this. When we take the history and examination, we find, sir, please, I'm changing the flow. Yeah. When you do the history and examination, you make a hypothesis. And then you try to investigate the patient and collect the data. And then you analyze that data. These are the 3 steps of making a diagnosis. Next slide. Right. The reasoning in our mind could be of 2 kinds. One is intuitive, which most of us who have spent around 30, 40 years in clinical practice and who have a large repertoire of large library of stored patterns in our mind. We know fever, cough, hemoptysis, these are the DDs. We know fever, body ache, rash, these are the. So people who are experienced, they use intuitive method reasoning more than the analytical method. Intuitive is rapid, effortless, pattern recognition, and heuristic. I'll come to what is heuristic means. But there is another way which should be followed by a fresh beginner, by a MD person, is analytical. That means you have a huge list of causes in front and you take it out. Gradually, slowly, effortful, methodical, deliberative, and it is good for students. Unfortunately, most of the MD students or most of the MBBS students are watching their peers, their professors who are using intuitive methods, not analytical method. And that's not a good thing to learn from right initially in the beginning. Next slide. Well, to give you an example of intuitive method, this is an intuitive method that we recognize patterns. Like if there is a 46-year-old patient with hemoptysis, if he's a smoker with 100 pack history of cigarettes and weight loss, we are thinking of malignancy. If he's a non-smoker, just was otherwise healthy, had a fever and cough, we are thinking of bronchitis. If the patient has a heart murmur and is from underdeveloped country like ours, our country is no more underdeveloped, it's a developing country, or maybe developed country, then we are thinking of mitral stenosis. So we are recognizing patterns. We are not going into analytical details, we are recognizing patterns, and this is intuitive. Next slide. But if you are analytical and you have a patient like that, you will have a list of causes in front of you and deliberately trying to take all the causes out of the thing. That is a beginner's way of learning, which is a good way of learning. But when you reach that experiences, then you become intuitive. Next slide. And what are the heuristic pattern? Heuristic, a copybook meaning or a dictionary meaning of heuristic is that proceeding to a solution by trial and error or by the rules that are loosely defined. There is always an error of judgment here because it is very fast. And what are the heuristic patterns? One is representative. That means if you have for example, hypertension, sweats, palpitation, you are thinking of pheochromocytoma. You are recognizing patterns. Availability is little difficult thing. The problem is that you remember rare catastrophic event much more in your memory than others. Like I will remember a case of metformin-induced lactic acidosis, which is so rare, but it'll be written in my memory very prominently. Like so these availability, that means there are available instances in your mind, but they are not the actual ones. Anchoring is when you stick to a diagnosis despite the testing are coming out to be negative. That means you are anchored into a diagnosis. It's not a bad idea. It's a good idea. I'll give you examples for it. And then OCAM, which causes simplicity. That means you think of the simplest explanation, and most of the time you'll be right. Like if there is like the patient of fever, cough, hemoptysis for 2 months, you'll be 90% right if you diagnose tuberculosis in your mind and make a hypothesis of tuberculosis. Next slide. There's one more pattern, heuristic pattern, which is called as search satisficing. That means you get satisfied with the first possible explanation of patient's presentation. I give you example. I have burnt my finger like this. There was a 50-year-old gentleman who was a case of ischemic heart disease, was on aspirin, and he presented to me with iron deficiency anemia, hemoglobin about 6.6, and it was iron deficiency. Now, because he was taking aspirin, and because we know that aspirin can cause upper GI bleed, my first thought went there. I said, stop aspirin. We gave him iron. Within 3 months, he became all right. But after 3 months, he was back to his anemia. And then we did a detailed search and we diagnosed cancer colon in that patient. Of course, luckily, it was treatable and he's still living today. I don't have to live with the guilt of doing something very grossly wrong. But this is what is meant by search satisficing. That means you get satisfied with the first explanation of the patient's presentation and you stop there. And that sometimes is really bad. Next slide. Oh, then we go for investigations because we made a hypothesis and now we want to confirm this hypothesis. I'm not going to go into the details of every investigation, but broadly what is important for investigation is we have all kinds of investigation, blood investigation, imaging intensive investigation, etc. Next slide is very, very important. Whenever you order an investigation, you have to answer these 3 questions in your mind. 1, first consideration, will it add to your treatment planning? If you are getting an investigation done for the heck of investigation and it is not going to change your planning, well, why the hell you are wasting patients' money? Second, which is very, very important, I'll give you example. What is the pre-test probability of the disease? Now, I give you example. A young woman of 20 years of age presents with atypical chest pain. You get an ECG done. ECG is normal. Now, what was your pre-test probability? Pre-test probability of a young woman with 20 years of age, atypical chest pain, is that it is not cardiac. And it matched with your ECG. And so you discharge the lady. Say, go home, don't worry. We will investigate you further. But another case, 50-year-old smoker presents with typical chest pain. Pre-test probability very high, ischemic heart disease. You get an ECG done, ECG is normal. Will you discharge this patient? You will interpret ECG as normal, but you will not discharge this patient. You will get other tests done. So very, very important to go back. What was your pre-test probability? And you anchor, you use a heuristic anchor model that I will stick to my diagnosis, do more tests. So second, this is very, very important. Sometimes we err on this. Third, please go back. Third is we must know each test sensitivity and specificity. There is no test in the world which is 100% sensitive and 100% specific. अगर ऐसा टेस्ट होता फिर डॉक्टर की जरूरत ही क्या? आप SLE का अगर एक ऐसा टेस्ट होता जो 100% सेंसिटिव 100% स्पेसिफिक होता, बात खत्म हुई, एक को टेस्ट कराओ, छुट्टी हुई. अच्छा है नहीं. Next slide. So, like to give you an example, ANA is nearly 97% sensitive, but only 82% specific to diagnose systemic lupus erythematosus. That means if it is negative, you are unlikely to miss a systemic lupus erythematosus. But if it is positive, in 18% of the cases, you are wrongly diagnosing SLE because it is not specific. Similarly, a fecal elastase, which I'm using for the last 5-10 years, much more than usual, to diagnose exocrine pancreatic deficiency, even in type 2 diabetes, is if it is the level of less than 200 is 63% sensitive, not very sensitive, but pretty specific. And the specificity of this test even goes to 100% if it is less than 100 microgram. So that means for every investigation you order, you must know what is the specificity and sensitivity. And at what level the sensitivity goes up, our specificity goes up. Next slide. Some tests are very misleading because of this reason, and we continue to use those tests, and those tests actually mislead us rather than lead us in the right direction. Some of those tests are, next, Vidal and Typhoid is this stupid test which has been misleading us for the last so many years, and I think it's time to stop using these stupid tests. Only 37% sensitive, 62% specific. Typhoid, 42% sensitive, 57% that. What is the fun of doing these tests? And I have seen R factor being used totally wrongly. Just R factor being positive. There is not even arthritis. Why the hell did you get R factor done when there is no arthritis? And you diagnose rheumatoid arthritis, start using immunological drugs, and start killing the patient. Next slide. And all of us know that in American College of Rheumatology criteria, at least 4 of these criteria have to be positive. Rheumatoid factor is just one of these criteria. The others are totally clinical. If your clinical criteria are not fitting in, R factor is of no use whatsoever. Next slide. And now we are lucky that we have now flow charts available because of one specific reason. I'll talk to you why the flow charts are more and more available now. So this is a flow chart. Joint swelling more than 12 weeks because we want to exclude viral polyarthritis. Yes. If it is yes. If it is involving 3 or more joints, yes. R factor possible, positive, then you diagnose. So it's not just one investigation by which you diagnose. Next slide. No. So can somebody say what is it? ChatGPT. So if you do not know artificial intelligence, if you are not taking help of artificial intelligence, you are much behind your time. Very soon, every doctor will have to use some other kind of artificial intelligence to diagnose patient, and it will be of great help. Next slide. This artificial intelligence is already into discovery of drugs and so on and so forth, but very soon it is going to come into imaging. It's already come to some extent in imaging, and very soon every physician will have a program of ChatGPT and feed in our data and take the help of Chat. AI is a very important technology, but AI is also going to be very destructive technology. All of us are aware of deep fake, by which you can make videos of any one of us with any fake videos. All of us are aware that we can also make fake voices also, and you can form. Next. Now, in the end, I'm going to talk about cognitive biases. Next. So one of the bias is this. I was reading this book, very important book to read, The Intelligence Trap. And I have given Einstein's photograph, but it has nothing to do with this book. This book says why very important people, very highly successful people, highly intelligent people make stupid choices, made stupid diagnosis and everything. And the reason is this. Reason is ego. When you become too big, you think you know everything. You think I don't have to follow any rules. I don't have to follow any flow charts. Why should I flow? I don't have to listen to my juniors. I don't have to listen to even my patient. And that is a trap. Then you start making stupid choices. Never, ever reach that space. We are always students rather than teachers. Next. And of course, this I have seen in my life so many times, not just once, but many times, and I've lost patient. It is called denial mode. That means the writing is right in the front of you. Its writing is on the wall. Any stupid person can read that, but you are not able to read it because the consequences of that acceptance is very bad for you. I give you 2 examples. A patient has been operated for intraoperative surgery, any surgery. The second day, the patient has high fever, rigid rigid abdomen, all the telltale signs of leakage inside. The surgeon doesn't want, many of the surgeons doesn't want to accept it because it means going back to the patient, reopening him, and the consequences are bad for him. So he'll try to tolerate. PR देखते हैं, septicemia है, antibiotic दो, रुक जाओ. अरे, there is nothing to रुक जाओ. You have to open it up again. And you are in a denial mode. Don't be in a denial mode. And of course, all of us know of very acclaimed physicians whose son was having a chest pain and had a classical inferior wall MI. And the precious time was wasted because, you go into denial mode. And never ever do that in a denial mode. So denial mode is one of the psychological aspects when you don't make a proper diagnosis. Next slide. And this, of course, is very, very important. If we are stuck in a situation where we are not able to make a diagnosis, we should take a diagnostic time out. That means the whole team should identify the red flags and the black flags within the history and examination and try to rethink about the diagnosis. One of the important things about this is, next slide, is that if you are too close to the picture will look blurry to you. If I have been treating a patient for hysteria for about 20 years, then every symptom in that patient will look hysterical to me. He has a classical chest pain of ischemic heart disease, and I think she's faking. I think she's hysterical, and this and that. So then what's to be done? Call another doctor. Except that you are not been able to diagnose, let me call another of my colleague who does not know the patient, who has never seen the patient from the beginning, and then ask him to see it again, and then he'll be able to make a better diagnosis. So this is one hurdle, psychological hurdle, which I have encountered in my life. Next. So the last few practical tips. Next. This I keep talking about it in medical colleges when I come. I said, stop treating spinally. You are treating spinally. You are not a spinal person. You are a cerebral person. Think यार, अगर आपने एनीमिया देखते ही आयरन शुरू कर दिया, ये आपसे बड़ा कोई गड़बड़ आदमी नहीं है. अगर आपने हाई डीएलसी देखते ही एंटीबायोटिक शुरू कर दी, तो आपसे खराब कोई आदमी नहीं है यार. उनको तो कुछ नहीं आता. You are not worth anything. Don't do this. And I'm talking to my MD and other person right here that please don't do this. I mean, don't develop into this habit of, think spinally. Don't act spinally. Think. Next. This is important. If not certain about the diagnosis, admit it to the patient. Admit it yourself. When the patient asks you, what I've got, I says, I don't know. I'm still searching. Be honest. And patient will not run away from you. It's a good policy. Honesty is a good policy even now, but it is a good long-term policy. Honesty is not a short-term policy. It's a long-term policy. Next. So if treating empirically, you should be ready to change because you are not definite. And so many times we have had to change. Many times you turn. Next slide. So I'll give you an example of this. If you're not sure, you should, when you are treating empirically, you should be ready to change. This is one of my recent patients who's around 60-year-old smoker who presented with hoarseness of voice. And when he went in for the ENT checkup, there was a growth right vocal cord. We were thinking it is malignancy. It didn't turn out to be malignancy. There was a granulomatous inflammation, probably of mycobacterial origin. His Mantoux test was slightly positive. We put the patient on ATT for 3 months. The patient did not improve. Now, this was an empirical treatment at the best. We did not see tubercular bacilli here. So when we did not see tubercular bacilli, you cannot be 100% sure. You may be all right, but so what happened later? Next slide. Well, he developed these skin lesions and mucosal lesions. And these are again biopsied and turn out to be histoplasma. This is a recent case. Mucocutaneous histoplasma is not very common. And this is what it turns out to be. And then we have put him on an antifungal treatment. He's improving very well. So whenever we are treating empirically, we should admit to ourselves that this is an empirical treatment and we should be ready to change. Next slide. So can any didactic program accelerate this progression from a novice to expert? क्या ऐसा हो सकता है कि हम कोई ऐसा प्रोग्राम चालू करो जिसमें एक फ्रेश एमबीबीएस ग्रेजुएट या फ्रेश एमडी ग्रेजुएट 30 साल के बराबर हो जाए? नेक्स्ट स्लाइड. नहीं हो सकता. And this is again a very important book for you to read, which is known as Outliers. That means whenever there is a bell-shaped cow, those people who lie outside that bell-shaped cows are unique people. And why do they become unique is being discussed in this book. And he says that for doing anything well, musician, software, anything, you have to pass the 10,000 hour test. If you have played tabla for 10,000 hours, you'll be a good tabla player. If you have done anything else, software, etc., for 10,000 hours, you'll be done. I mean, you'll be good. So there is no shortcut. It is only by years that you will gain experience. Next slide. But we should not confuse motion with progress. ऐसा नहीं हो सकता कि हम में से सारे लोग ये कहें कि मैंने 40 साल का एक्सपीरियंस है और सबको 40 साल का एक्सपीरियंस हो. And I end with this slide. Next slide. My guru, my teacher who taught me everything, Dr. Ellis, he once said, if you are practicing with your eyes and mind closed, it is your inexperience which is being multiplied by the number of years you are putting into the job. So आप 40 साल experience नहीं हो, आप 40 साल inexperience हो, अगर आपने काम आंखें बंद करके किया. Next slide. Thank you. Thank you very much.
Thank you very much, Dr. Swami, for your wonderful talk. You have made it, things look very scientific as well. So, as I know, customarily innovation, no questions are usually allowed to ask. This is a tradition for the orations. So, we can have a discussion and whatever we want to ask from Dr. Swami or from any one of us, we can discuss later on the lunch or at the tea break. Thank you very much. Thank you.
Sir, it's totally lovely to know that he is invited. So Sunday has taught me in undergrad course, MBBS, and also I was his resident by the University. Thanks again, sir. I just would cite one example of his teaching. I was working in a very busy hospital. About a 75-year-old person came to me in a very busy OPD. He said, "Doctor, I want to tell my awful tale. Ab sahab, मैं आपको अपनी दर्द की दास्तान सुनाना चाहता हूँ." And I committed a mistake. आज इस मैं इसीलिए बैठा हूँ, सुनाइए दास्तान. And he started. He continued for 5 minutes. I realized my mistake, but I then could not go back. He continued. डॉक्टर साहब, आप पहले डॉक्टर हो जिन्होंने मेरी पूरी दास्तान सुनी है. अब मुझे कोई तकलीफ नहीं. It's a true story, sir. And then I prescribed him one or two drugs, and when he came to me, he said, "Perfectly all right." सबसे बड़ी दिक्कत ये है कि डॉक्टर सुनने को तैयार नहीं है. आपका बहुत बहुत शुक्रिया. थैंक यू. धन्यवाद. इतना अच्छा पढ़ाया आपने. पहले अच्छा पढ़ाते थे, आज तो आपने बहुत ही जादू कर दिया. प्लीज वी विल बी हैंड यू.
Thank you, sir. The way you convey your thoughts were both engaging and clear. It would definitely leave a lasting impact on everyone present. It is always a pleasure to hear your wise words. I would like to request Dr. Saurabh Singhal, sir, to kindly come up and facilitate our speakers. Dr. Sondi, sir. And the chairpersons, Dr. V.K. Bindra, sir, Dr. T.V.S. Arya, sir, and Dr. R.K. Aran, sir. I would request the chairpersons, Dr. TBS Arya sir, Dr. VK Bindra sir, and Dr. RK Anand sir to please kindly come forward. Dr. TBS Arya sir. I would request Dr. Saurabh Singhal sir to come forward and say a few words and declare the conference open.
Good morning, everyone. It is with great pleasure and sense of immense responsibility that I stand before you today to declare open SUMECON 2024. This gathering represents a confluence of brilliant minds, dedicated professionals, and passionate individuals, all united by a common purpose, the pursuit of knowledge and the development of medical field. In this room, we have clinicians, researchers, and educators from various corners of the medical field, all driven by a shared commitment to improve the healthcare, unraveling the mysteries of diseases, and enhancing the quality of patient care. The theme of this conference is medical emergencies. When I thought of this conference, the topic first came to my mind was cancer awareness. But yes, already the Subharti University is doing very much about cancer awareness. So I restricted to my own topic, that is medical emergencies. So medical emergencies which resonates deeply with the challenges and opportunities that define our era in medicine. It is a call to explore new frontiers, collaborate across disciplines, and harness the power of innovation to confront the complexities of healthcare today. As we embark on this intellectual journey together, I encourage you to actively participate and ask questions, share your experiences, and forge connections that extend beyond these conference today. Thank you, and I wish everyone a rewarding and enriching experience throughout the conference. With this, I would warmly welcome you to all for a small breakfast. After that, we will continue with the next topic of the day. That will be again a very interesting topic. And for that, we have with us our very own Dr. Amit Rastogi, sir. The adrenal crisis. Yes, it is a very interesting topic. So rejoin after the breakfast. Thank you so much.
Someone has rightly said that breakfast is a way of saying good morning to your body. It is not just the most important meal of the day, it is the best meal of the day. With this, I invite everyone to join us for breakfast, and I will see you on the other side of this conference. Thank you. and Dr. Prabhat Agarwal sir and Dr. V.D. Verma sir. Dr. Abha Gupta ma'am has been serving as the Professor of Medicine in LLRM Medical College, Meerut. She's an Assistant Professor of Medicine in Himalayan Institute of Medical Sciences from February 2001 to 2005. She did her fellowship of Indian College of Physicians, IACM and Diabetes India. She has published 6 chapters and 3 papers in the international and 20 publications in journals. She has been awarded as the Bharat Jyoti Award in 2015. She has been awarded the Professor B.C. Bansal Best Paper Award in 2016. She is the Investigator of the Year 2017 and 18 awards by the Indian Society of Hypertension. Welcome you, ma'am. Next in a panel of chief chairpersons is Dr. V.D. Verma sir. Dr. V.D. Verma sir did his MD General Medicine in 1986. He has been serving as a clinical, administrative and research experience of more than 35 years. He has worked as faculty of JIMS Greater Noida. He has worked as Professor General Medicine at ASMC, Shahjahanpur and Pratapgarh. He retired from government as an additional director. Next in our panel of chairpersons is Dr. Prabhat Agarwal. He has been working in managing medical emergencies and fostering positive relationships with the patients and their families. He's a life member of various medical societies. He has been awarded as the Meerut Ratan and several other awards for his relentless work and saving lives in COVID. He has been a practitioner with over 30 years of experience in Meerut. I would now request Dr. S.P. Sondhi sir to come forward and introduce our speaker for the day. That is Dr. Amit Agarwal sir.
Thank you very much. And I think this is a privilege to introduce Dr. Amit Rastogi. And he's been with us in practice, and there is no better way to judge a person than to see him practicing. And we have seen him practicing. He has a lot of award to his credit. Dr. N.N. Gupta Gold Medal in MD Medicine, Best Candidate, and he's showing it up with his practice. He's consistently engaged in a lot of teaching program, and in at least one program we were together, we were with the RSS, PHFI program of this thing. So we were together and we were doing it. He has been an executive member, API Meerut chapter of World Integrated Society of Diabetes Endocrinology, but there is nothing better than having a piece of cake and enjoying it, and then you will know how tasty he is. So over to you, Dr. Amit.
So thank you so much, sir, for those kind and encouraging words. I'm always blessed to be part of Subharti family. My career started with working under the guidance of Dr. Atul and Dr. Mukti ma'am, Dr. Sondhi sir. I first presented him the case of medicine and he came to know that yes, somebody has come in Meerut city. So Dr. Aaron sir, and they have been a blessing to me, and I hope they will show as always. So friends, we have gathered here to talk about a very pertinent emergency which we face in the field of endocrinology. We all endocrine की बात होगी तो diabetes ही आएगा, and we have hypoglycemia, we have diabetic ketoacidosis, honk, we have hypocalcemic crisis, hypercalcemic crisis, to name few. But this one is quite important, and we as a clinician must have an access to how to diagnose and suspect it. And I'll make matter much more interesting by presenting a case which I did in 2018 in a mid-semester psycho-neuroendocrinology conference in Subharti itself. That case still holds good. So it is a potential fatal condition. So we need to have an insight of all those conditions which are fatal. An acute adrenal insufficiency is elusive diagnosis. You should have a high level of suspicion. Dr. Sondi has given a very clear message to all of us, art of diagnosis. And this is one of the entity where you have to keep your eyes and mind open. And you must know a little bit about adrenal insufficiency, and therefore you will be able to diagnose it. Believe me, it's very rewarding. It's very rewarding once you treat a case of adrenal insufficiency. Every emergency or critical care physician must know about this entity. The diagnosis and decision is presumptive. This is presumptive. Intuition. At times it holds good. And based upon history. Sir pointed out, 60 to 70% of the diagnosis is reached just by taking the history of the patient. Rest is by exam, and then lab comes into picture. But delaying the treatment in this particular entity, well, पहले diagnosis बना लें, उसके बाद treat करेंगे, is not done. You have to start with the treatment and save the life of the patient, and then you can entertain the diagnosis of adrenal insufficiency. What was the reason that patient went into adrenal insufficiency? This is a typical feedback mechanism which we see in endocrinology, every system, and one of them is hypothalamic pituitary adrenal axis. The first tier we have hypothalamus. It sends signals to the corticotroph cells on the pituitary by CRH, that is corticotropin releasing hormone. Then the pituitary secretes ACTH. ACTH goes and acts upon the adrenals. We know that adrenal have cortex and medulla, and cortex further have three main layers: glomerulosa, fasciculata, and reticularis. One point to remember is that this mineralocorticoid secretion is hardly dependent upon ACTH. It is primarily based upon renin-angiotensin system and serum potassium and sympathetic. Point to remember. Whereas the cortisol secretion is entirely dependent upon ACTH. Level of defect, whether it is at the hypothalamus or at the pituitary or at the adrenal glands, will settle the diagnosis whether it is tertiary, secondary, or primary adrenal insufficiency. For example, if the defect is at the hypothalamus, we have a case of craniopharyngioma, and a neurosurgeon operates it, and therefore the hypothalamic is destructed, so too is the pituitary. Second is pituitary. We have non-functioning pituitary adenomas, very common, seen, or patient have an empty cell syndrome. There the patient will be having adrenal insufficiency. And if the insult is directly on the adrenal glands, then it is the primary adrenal insufficiency. How do you differentiate between these two entities? By insufficiency, cortisol will be low, but ACTH will be high, because the signals are sent to the pituitary, and pituitary is intact, and it will secrete more of ACTH. But in cases of hypothalamic and pituitary or the central adrenal insufficiency, the ACTH is low. So here, cortisol and low ACTH. And what other difference will we have? We have the aldosterone or the mineralocorticoid activity, which is intact in secondary and tertiary, but in primary it is off. So these are simple rules of endocrine, and we need to have something of the basic knowledge how adrenal axis works. We must go, I will not go through the exhaustive causes of adrenal insufficiency, but I will highlight some of the pertinent cases which we have seen. According to the Indian series from SGPGI Lucknow, the commonest cause of primary adrenal insufficiency is adrenalitis. In Western population, you will see it is autoimmune adrenalitis. Dr. Sodhi sir presented a case of histoplasmosis. And I am sure that when I was doing my DM training in BHU, one of my known was sent to the elite panelist, which sir have a discussion on Wednesday 1. And there was diagnosed a case. And at that time, the treatment was given from BHU, from Dr. Shyam Sundar. He is an expert in that. So this was how the query was solved. So histoplasmosis is one of the fungal infection which may lead to adrenal insufficiency. Malignancies, you may have adrenal masses, but you require at least 90% of the adrenal gland to be destructed. Therefore, adrenal insufficiency in patients who have metastasis of adrenal glands. And hemorrhage. If the patient have intra-abdominal bleed or trauma is there, patient is on anticoagulant, the adrenal hemorrhage can occur and may lead to necrosis of the adrenal gland. In secondary cases, just 2 or 3 gratifying cases, the commonest variety of adrenal insufficiency which we encountered is the tertiary or secondary adrenal insufficiency. It is in those patients who who have been exposed to chronic steroid for a long period of any steroid which is given weeks will not cause suppression of HP axis. But if the steroid is prolonged and there is sudden withdrawal of steroids, the patient will lab into adrenal insufficiency, and that is the commonest cause of adrenal insufficiency or crisis which we see in clinical practice. There can be empty sella and hypothalamus, which we have discussed. So remember this particular part. Abrupt withdrawal of steroid in a patient who is on prolonged steroid therapy is the commonest cause of adrenal insufficiency or crisis which we see in clinical practice. This is a diagnostic workup of a patient of adrenal insufficiency. So only two hormones are required, cortisol and ACTH. We have just gone through that part. Cortisol is following a circadian rhythm secretion. It follows the day and night as well as sleep and wake cycle. So therefore, we measure cortisol in the morning, fasting state 8 to 9 a.m. Remember the three figures. If the cortisol level is less than 3, you entertain the diagnosis of hypoadrenalism. If it is more than 50, you rule out. If less than 3, you then have to ascertain whether it is primary or secondary. And I've just explained, get an ACTH done. If ACTH is high, it is primary. If ACTH is low, it is secondary or tertiary. But what happens if it is between 3 to 15? It is a so-so case. You need to confirm it. And as a principle in endocrinology, we have to do dynamic testing. You have to give ACTH from outside and then see what is the response of cortisol. So soonly we have ACTH, synthetic ACTH available with us, but now it is off market. And I was very surprised and was pleased that I received a call lately from a surgery department of Subharti Medical College. How do you assess the excess of HPA in today's scenario? So the solution is very simple and clear and is very practical, and we can do it in our own setup. There is a preparation of ACTH known as actin prolongatum. It is easily available. It is given for Guillain-Barré syndrome. It is given for other things, but you can use it. So what you do, it is available at 60 units per ml. You have to withdraw 16 units of it. How? From an insulin syringe, which is 40 IU per ml. Dissolve it in saline and give intramuscular and deltoid region and measure cortisol after 60 minutes. This constitutes the dynamic testing. I think this must be practiced in our department. And if it is more than 18, it rules out. If it is less than 18, it entertains a diagnosis of adrenal insufficiency. I think this much part is clear. And the test which I just mentioned can be done now. So do a lot of these tests, especially in those patients who you suspect adrenal insufficiency. So why do a patient lands up into adrenal crisis? A patient who have a deficiency of cortisol, either because of primary adrenal insufficiency, meet or come across a particular stressor. This stressor can be in a form of infection, in the form of trauma, burn, or a major surgery or general anesthesia. So the patient body is not able to produce cortisol to combat that stress. These are the symptoms which we must be alert of. Some of them are very vague. Some of them are very gratifying to reach to the diagnosis. For example, patients having cortisol deficiency will have vague symptoms. ये सभी बीमारी में मिल जाएंगे, like fatigue, lack of appetite, anorexia, weight loss, diarrhea, joint pain, hypoglycemia. You can get in every innumerable, कोई भी condition inflammatory उसमें सब मिल जाए. Lack of aldosterone will lead to salt craving and a typical point and postural hypotension. If the ACTH get typical tanning, and that should not be missed. Tanning in the post part. Recent scars but not old scar. अगर adrenal insufficiency के बाद चोट लगी, scar आया, वो pigment हो जाएगा, पुराना वाला नहीं होगा. So therefore, you can have a gist of temporal origin of adrenal insufficiency. Mucosal, like the buccal mucosa, the anal surface, they all will be pigmented. Look at the palms. skin pigmentation, they will be pigmented. And as been taught, don't be biased with pigmentation. It can be in other cases also. B12 deficiency may lead to having characteristic look. Need to decipher. How do we go ahead with the workup of adrenal insufficiency or in crisis? Simple tools, not a rocket science. Keep your eyes and ears and mind open. Have a basic knowledge of adrenal insufficiency. To the clinical scenario, you reach to the diagnosis. A complete blood count. लगता है मजाक कर रहे हैं. But cortisol have its own effect over the CBC. The typical one is eosinophilia. The eosinophil counts goes down. Eosinophilia is a the cortisol will go high. It is known as the, or we call as the bioassay for cortisol. Electrolytes, utmost importance. Always pay heed to the paired value of sodium and potassium. Sodium going down and potassium going high. Always. And it's a I think very characteristic of adrenal insufficiency. Plasma glucose may go down because we know cortisol is required for gluconeogenesis. Agar cortisol ki, therefore the patient will land into hypoglycemia. Cortisol and ACTH. Before, this is, I do not entertain now medicine for a couple of years, but then whenever I used to get a call from ICU setting, डॉक्टर साहब इसका cortisol तो 100 हो गया, ये तो Cushing disease की patient हो. But then the problem, the emergency people have already given hydrocortisone in the night, and in the morning when the clinician come and draws the sample, it is sky high. Hydrocortisone will interfere with the cortisol assay. So अगर किसी को hydrocortisone लगा दिया और उसका आप test लगाएंगे, it will be high. But if you will give dexamethasone and check cortisol, it do not interfere. There comes the importance of lab. And before giving steroid, if you are having a slightest suspicion of adrenal insufficiency, draw the sample, store it and send it to the lab. कौन सा? Cortisol and ACTH. Because दोनों का pairing से you will be able to diagnose as well as you will be able to reach that where the defect lies, primary or secondary. Thyroid function, everything can be adjusted later on. You can have a imaging, CT scan abdomen for adrenal masses, adrenal hemorrhage, adrenal atrophy. And lastly, you can have an MRI pituitary to look for any pituitary mass or empty cell. So this is quite simple. I think there's nothing rocket science in it. Now comes the bench to bedside case. As I was just referring to, this case I presented in 2018 here in Subharti Conference of Psycho-Neuro-Endocrinology. The presentation was psychiatrist, like psychosis, anxiety, and let us see. 21 years old male presented with fever and vomiting, which we had for 6 days. Just in this case, अभी लगेगा कि बहुत सारा ग्रंथ बता रहे हैं, मगर then I'll give a snapshot of it. Everything was fine. Patient was having low blood pressure, fundus was normal, hospitalized, symptomatically managed. इस 21 years में vomiting हो रही है, gastritis हो गया होगा, fever है, छोड़. Discharge on 27. Investigation, upper GI endoscopy कर ली, peptic ulcer disease now, कुछ नहीं निकली. See, the presentation was fever. And I think that is blood pressure was on the lower side. Second admission, just 4 days, 5 days back. Here the patient presented altered behavior and visual hallucination. CT scan was done, क्योंकि neurological feature आ गए थे. There was a clue here. Sodium and potassium. After stressing upon that particular, I think that can be correlated now, but that's what missed. ये कौन सा admission हुआ? Second. Discharge second, found to have a psychiatric features. Discharge on Serenase, Pacitine, and Atizolam. Follow up, sorry, with due respect to the treating physician, because the Serenase and Pacitine was continued. He again present working diagnosis was psychosis with hyponatremia. You can get neuropsychiatric features with hyponatremia. But as sir told, giving iron in an anemic patient is a blunder. You need to reach the diagnosis. Here also, hyponatremia cause was not entertained. And its correlation with potassium was not entertained. Here आया sodium on the lower side. Again presented with vomiting and episodes of psychotic behavior. Potassium was high, sodium was low. Third admission was on 8th May. Similar features, stereotype, discharge, same treatment. Fourth also, presenting the same, sodium, potassium is high. Kitte visit, kitte admission. Now comes the game changer. And what was the game changer? Something miraculous happened. And the treating clinician and the team noticed hyperpigmentation of the patient. And this changed the entire psychotic theory. Here is the brief of the patient. 5 admission, 28 March since 9 June, similar presentation. But what happened with if we join the triad, vomiting, psychotic behavior, low sodium and hyperpigmentation, I think the diagnosis is clear. And can anybody say where the defect lie? It is a primary or secondary because of pigmentation. And what do you? And this was the biochemistry. Cortisol less than 3, remember. It was just 0.56. ACTH 230. With this pigmentation, you can see the lip. If you can make out the, and this is the palmar crease. And after treatment, what happened? You can see, make out the difference. I had a picture of his elder brother for the comparison, and you can see the palmar crease pigmentation. Can you make out the difference? It is clear. These are the pigmentation, these are after. So these pigmentation are reversible. So this is what a case of adrenal crisis can be like, and it is very rewarding. How do we manage an adrenal crisis? As a basic rule of medicine, you are more learned than me now. That is airways, breathing, and circulation. And these patients are volume depleted because cortisol enhances the pressure agents, catecholamines and epinephrine. So therefore, they are in shock. You have to give isotonic saline, about a liter in 1 hour, followed by 2 to 4 liters, depending upon the hemodynamic status of the patient. Always draw the sample for cortisol and ACTH before giving a shot of hydrocortisone. अगर वो भी नहीं मिलता है ना, तो कह दो कि दे दो भाई cortisol, बाद में देख लेंगे. Don't wait. It is so important. And then some of the patients may be hypoglycemic. You can give 5% dextrose or 25% dextrose depending upon the clinical condition. This is the story of steroids. How do we go about it? You have to give 100 milligrams 6 hourly IV, or you can give even intramuscular, or you can give an infusion of cortisol, accounting to 200 milligrams per 24 hours. This is day 1. Then you taper it off to 50 milligrams 6 hourly. And then when the patient is able to take orally, shift to patient on oral hydrocortisone. One important thing which I saw in the literature as I was going and preparing the slides were that often missed in primary adrenal insufficiency is introduction of fludrocortisone. People will give prednisolone, hydrocortisone, and they will forget about fludrocortisone. So therefore, in patient of primary adrenal insufficiency, both steroids should come into play. And when you are giving hydrocortisone in a high doses, it has mineralocorticoid activity. Therefore, we do not give fludrocortisone when the patient is on IV. So dose of hydrocortisone more than 50 to 100 milligrams per day will automatically have mineralocorticoid activity. And then you can shift the patient to hydrocortisone or prednisolone, whichever suits to your patient for the convenience. This is the snapshot, just gone through. Give hydrocortisone, 100 milligram bolus, followed by 200 milligram per 24 hours. IV fluids, isotonic and dextrose. In ICU setting, give low molecular heparin for pulmonary embolism. And then you have to give mineralocorticoid in patients of primary adrenal insufficiency. Long-term monitoring. Don't leave the patient like this. We have managed crisis. These patients will be on lifelong corticosteroid therapy plus minus mineralocorticoid depending upon the cause of adrenal insufficiency. So maintain the dose. The maintenance, the physiological dose of hydrocortisone is 20 to 30 milligram per day. You'd give it in divided doses. 2/3 in the morning, 1/3 in the evening. Don't give steroid in the night because it will interfere with their sleep and will have some behavioral issue. So better would be to give a split doses of hydrocortisone. Mineralocorticoid, as already explained. How do you follow them? Cortisol ke liye, weight, well-being, and blood pressure. And for mineralocorticoid, you need to have the blood pressure, both supine and standing, postural drop dekhna hai, electrolytes dekhna hai, blood pressure dekhna hai, and at times, I do not do it in practice, is renin activity. When the mineralocorticoid is low, renin activity goes high. So you can get a plasma renin activity done. Costly test. We can go ahead with the basic test of electrolytes, postural hypertension, and quality of life. Always advise the patient for stress doses. This is a must, often missed. अगर किसी की पिट्यूटरी सर्जरी हुई है, patient is a case of central hypoadrenalism or primary, stress doses should always be explained when to titrate the dose. Up titrate the dose. Who are the patient whom you will suspect of having adrenal crisis? Those patients you suspect have primary adrenal insufficiency. How? For example, patient have other autoimmune disorder. Hypothyroidism है, Hashimoto's thyroiditis है, type 1 diabetes है. Type 1 diabetic, hypothyroid, now going into recurrent hypoglycemia, thought of adrenal insufficiency. Patient have bilateral adrenalectomy. Have you seen a case of bilateral adrenalectomy? Cushing disease के अंदर जब कुछ काम नहीं आता तो adrenals उड़ा देते हैं. दोनों adrenals निकाल दिए, cortisol कम हो गया, but then the patient lands up into adrenal insufficiency, will require steroid throughout his life. Or the patient have an history of any pituitary surgery or radiation or traumatic brain injury. Most important thing is history of chronic steroid intake. Always remember this golden rule. यही काम आना है clinics में. कि if a patient have any route, even inhaled steroid given for a long time may cause adrenal suppression. Patient who have been on exogenous steroid, those patients you are giving for flare of rheumatoid arthritis. For any autoimmune disorder, you are giving steroid. Always teach them what are the sick day rule. I'll come to it. What is sick day rule? This is quite important and very interesting. I think this must be known. Patient of yours who is on a pharmacological dose of steroid, prednisolone, say 40 milligram or 60 milligram per day. How do you taper it off? It's very, very common problem which we face. So you reduce the dose of prednisolone by 2.5 milligram till you reach the physiological dose of steroid. What is the physiological dose of prednisolone? 5 to 7.5 milligram per day. Uske baad you shift it to hydrocortisone. The equivalent dose is 20 milligram per day. And then you bring it down to 10, give it for a couple of months, and then you check the excess. You withhold the cortisol, hydrocortisone for day, 24 hours, measure the steroid level. If it is less than 3, the patient is still deficient, you need to continue it. If it is more than 20, that means your patient has recovered. The HP axis has recovered. Or if the patient is lying somewhere between 3 to 20, you do a synectin stimulation test. Or what I've just discussed about synectin or actum prolongatum can be taken into person. Sorry, because I've taken the consent, that's why I'm not hiding their eyes. What do you think these two, they are brother and sister? And they presented me with this condition. So what do they look like? One is, that is facial puffiness is hypothyroid. Second, in the context of what we are discussing, these are Cushing's. You can make out moon faces and round faces and everything. This is a typical Cushing's. दोनों बच्चों को Cushing's हो गया. So there are very rare entities in pediatrics endocrinology when we have a familial Cushing syndrome. Very difficult to digest. Basic test क्या कर सकते हैं पकड़ने के लिए कि ये Cushing syndrome है कि adrenal insufficiency. Get a basal cortisol level done. Basal cortisol level was less than 1. दोनों को ही हो गया. ये कैसे हो गया? After grilling and grilling and grilling, बाद में पता लगा after 4th visit कि इनके दादाजी होम्योपैथिक ट्रीटमेंट देते हैं इनको. और वो कैसे कहते हैं, गोलियां नहीं थी वाइट क्रश करके. And then I came to realize that this was nothing but iatrogenic Cushing's leading to adrenal insufficiency because this guy, both of them were admitted with vomiting and fever. And therefore they were presented to. So cortisol, simple hai. Get a basal cortisol done whenever you are in a fix. If it is low, your diagnosis is entertained. It is adrenal insufficiency because of chronic steroid intake. हवा से आया, पानी से आया, खाने से आया, कहीं से भी आया, आ जरूर गया. Because cortisol was low, it is fitting into the clinical perspective. Moon faces, buffalo hump, I didn't take the sideward photograph, but they have buffalo hump, truncal obesity. And then you can visualize, see the difference between the two faces after treatment. You can make it out. The puffiness, everything is gone after 6 months treatment. So this was a nitrogenic Cushing's with secondary adrenal insufficiency. And then slowly and steadily we tapered the dose of steroid. And this is the clinical outcome. Always ask the patient who are on steroid to carry this card. And always explain them about the stress dose. These are the sick day rule. Mild stressor hai, increase the dose by 2 to 3 units because this is the time where your clinical advice will come into play to avoid adrenal crisis. आपका patient steroid पर है, चल रहा है, fever हो गया. You didn't ask the patient to double up the doses. Patient will land up into crisis. In moderate stressor, for example, patient going for general anesthesia, you give the dose in the dose of 50 to 75 milligram. And if the patient is a severe stressor, the standard dose is to be given. If the patient is not able to take orally, give them injectable. Simple rule, mild, moderate, and severe. This is the equivalent doses. I think it will be, you can get it anywhere. So hydrocortisone 20, prednisolone 5, and dexamethasone 0.75. These are the interchangeable doses of. Just 1 or 2 slides about this particular entity, though it is not a part of it, but this is my tribute to Dr. Mukti. She insisted me to present this in a critical care society for the first time when I was new to the city. Amit, tum hi jaake bologe. So this was in 2017 and 18. This is critical illness induced cortisol insufficiency. I think those who are managing ICU will be well versed with this, how to go about it and how to diagnose it. This is what happened. You have to just take a random cortisol and you do to have a synectin test. This is the only entity where the delta value pre and post comes into play. If it is more than 9, it is not having adrenal insufficiency. If it is less than 9, there is efficiency. Only in patient with septic shock, those who are not responding to fluid and high dose of vasopressor requires steroid, not everybody. So patient with sepsis without shock, no role. Patient who are on RDS, ARDS, you give methylprednisolone. Here you give hydrocortisone. Just you have to keep, if you're giving the patient, resuscitating the patient is in shock, resort to this particular thing. Finally, the take-home messages, high level of suspicion in a patient who is presenting to you with shock, not responding to all those missions. History, clinical exam and clinical labs, as the case I discussed, was very important and very rewarding also. Don't wait for workup. हम तो आज ही diagnosis बनाएंगे primary secondary की. Just start the treatment, procure the sample of cortisol and ACTH before giving a shot of hydrocortisone. Find the stressor. What led to this condition? Was it fever? Treat it. What is trauma, burn, or anything? And last but not the least, sick day rule must always be remembered in the patient who are on chronic steroid therapy. Thank you so much for the patient day.
Thank you, Dr. Amit, for a wonderful presentation. Just for the PG students that they want here, I have a couple of questions. Number one, as you rightly said, septicemia is one of the most important factors which exposes the undiagnosed adrenal insufficiency and also the thyroid insufficiency. So for the PG students, since the many the signs and symptoms are common with both, like hyponatremia or the low blood pressure, especially if it is a case of secondary or the tertiary adrenal insufficiency. So if the patient of septicemia coming in the emergency, so what are the cardinal features which will differentiate between the two? And this is also very important because if you misdiagnose adrenal insufficiency and thyroid insufficiency, it starts atrophy, because in both of these conditions you have to start the treatment before confirming the diagnosis. And you start the saying that will further increase the demand for steroid. So what are the cardinal features for the
Very,
patients?
very pertinent question, ma'am. And it is quite difficult to differentiate between the two. But then,
So what do we do?
yes. So if a patient of hypothyroidism is coming to the emergency, believe me, it's myxedema coma, and you will be able to differentiate between the two entities. See, in adrenal crisis, the patient is lean and thin, hyperpigmented. We are talking about primary adrenal insufficiency. Whereas in myxedema, the patient will be bloated, peripheral this, you will have hung up reflex, hyponatremia. Potassium may not be so that rewarding. But one thing of importance is that these two conditions can coexist, as we see in the cases of polyglandular endocrinopathy. So PGA1 and PGA2 can have both the deficiencies, and it's a basic rule. If you are suspecting a myxedema coma, never give levothyroxine without the cover of steroid. Never ever give it, because you will precipitate the adrenal crisis. Agar florid hypothyroidism hai, so we expect that that is HP axis is also stunted and obtunded. So it's a basic rule. Kuch bhi ho, when especially this occurs in the patients who are having a secondary adrenal insufficiency or hypopituitarism, where both of them coexist. So you'll be tempted to write levothyroxine without checking the cortisol to theek hai, but then you should all hyperpituitary. So and in adrenal insufficiency, if they can also have vitiligo also. It was classically described. So these two things, when you are dealing in the emergency, that myxedema coma becomes quite obvious, and you have to give a baseline steroid support, because steroid comes in the management of myxedema coma. This is another medical emergency we feel in endocrinology.
And take out the sample from our.
Exactly. Always procure the sample before giving anything. Endocrine का basic rule. बाद में दिक्कत हो जाती है.
Endocrine का एक और basic rule है जो प्रोफेसर जे के अग्रवाल सर बताते थे, आपको तो पता होगा कि ये रेनॉन एंडोक्रिनोलॉजिस्ट. सबने बोला कि एंडोक्रिनोलॉजी में एक चीज होती है कि जब सस्पेक्ट करते थे डायरेक्ट टेस्ट करना होता है. डायरेक्ट टेस्ट का बेसिक रूल एंडोक्रिनोलॉजी में कि कोई चीज कम है तो आपको स्टिमुलेट करना है, और अगर कोई चीज ज्यादा है तो आप सप्रेस करनी है. सप्रेशन टेस्ट चलेगा, और अगर एड्रेनल insufficiency है तो
stimulation test. Perfect.
My second question is the cortisol has diurnal variation, and 8 to 9 is when it is
maximum
peak. So you said that if levels are less than 3, you diagnose adrenal insufficiency, and if more than 15, you rule out. But अब पेशेंट किसी भी समय आ सकते हैं, तो कुछ रैंडम वैल्यू भी है, जैसे हमें you said कि take out the sample for cortisol, और हो सकता है इसी केस का ना लिया हो, तो कुछ ऐसी कोई रैंडम शुगर में होती है.
Yeah, it is difficult to just justify the case of adrenal insufficiency on the random sample of it. And believe me, the diurnal changes, we exploit this diurnal change secretion of cortisol in patients who are having Cushing disease, not in the cases of adrenal insufficiency. कि morning and evening sample लेकर के देखिए diurnal variation है कि नहीं है. It occurs in cases of Cushing disease, in hypercortisolism, not in hypocortisolism. But then you can do it. You can conduct the synectin stimulation test any time of day. But then you have to you don't have to rely on the basal part. You have to do a stimulation test.
My question is, patient आया रात में 10 बजे अपने सैंपल ले लिया, ठीक है, जैसे आपने कहा कि एक सीरम कॉर्टिसोल एसिड, मान लो आपने एसिड नहीं लिया, अगर आप कपल ले रहे हैं तो इट्स वेरी इजी टू डायग्नोज. तो अगर आपने 10 पीएम पे सैंपल लिया, तो कोई एक वैल्यू है जो कट ऑफ करे कि वो रूल आउट टू 15 बॉडी में है.
वही कह रहे हैं मैम, फॉर डायग्नोसिस ऑफ एड्रिनल insufficiency there is no cutoff value for cortisol in the night.
Okay.
Then you have to do a dynamic testing in the morning, which you can do anytime.
So you should take serum cortisol ACTH level.
Exactly. It is easy. Stimulation test. And it is that's why I discussed this. Actin prolongator is very easily available. You can do it, do the test.
Synectin is very easy.
Synectin मैम shortage हो जाती है. अभी आया था फिर चला गया.
Use हो जाता है.
Yeah.
Okay, thank you.
Thank you.
I just had one query. I have read somewhere that serum sodium potassium coordination, that means sodium going down, potassium going up, is a very good marker of picking up. But I just read it is present in only 30% of patients.
Yes.
So it's not really sensitive test. So don't think that if your patient does not have this sodium low and potassium high, that he cannot have, adrenal insufficiency, because it is present only in 30%. It's a good. If it is present, well, you are lucky. But if it is not present, your patient does not have.
And the hyponatremia diagnosis, we say that is SIADH, syndrome of inappropriate ADH secretion, and you go through that algorithm, you find you have to rule out hypothyroidism and hypoadrenalism to entertain the diagnosis of SIADH, because cortisol help in secretion of free water from the body, and it is antagonistic to AVPH.
Sir, is the effect of inhaled steroid, how much the quantum of effect? How much effect?
Long-term steroids, that I can just give you a gist, because you have to be alert in the patients who are on chronic inhaled steroid therapy. It is specifically seen in children. Children's may you give a steroid for bronchial asthma for a long period of time, intermittent inhaled steroid. And if the patient lands up into one of the features as suggested of adrenal insufficiency, you need to check this. Routine checking is not required. Routine checking is not required, just on the basis of symptoms you have to take into account. Or if the patient goes into any severe crisis, for example, fever ho gaya, and you're finding that patient is in shock, that's the where you have to, as a such, steroid ke baad frequent episode, periodic testing is not required. But have to be on alert with inhaled steroid also. That thing is sure.
Any question from audience?
The postgraduate students, any questions, any queries? We have a very learned speaker with us, Dr. Amit Rastogi. He is a master in his field, and the topic is also a very day-to-day topic which you are not aware. If you have any question, you can ask him at any time. He is open to at any time. Thank you, sir, for sharing your expertise and dedicating your time to deliver such an enlightening lecture. Your profound understanding and expertise on adrenal crisis was truly evident throughout the lecture. I would now request Dr. Saurabh Singhal, sir, to felicitate the speaker, Dr. Amit Rastogi, sir. And the chairpersons, Dr. S.P. Smoothie, sir. Dr. Ava Gupta, ma'am. Dr. Prabhat Agarwal, sir. And Dr. V.D. Verma, sir. Thank you, sir. Dr. Amit Rastogi, sir, while you are still here, I would request you to pick up a lucky draw winner and award them with an exciting prize. Dr. Abhijit. Dr. Abhijit Kalankar. Dr. Abhijit. He is our first year student, postgraduate student. So he has been selected for a lucky draw. After every talk, we will be having this lucky draw. So be there. First lucky draw. Dr. Abhijit. For our next academic session, I would like to invite our honorable chairpersons, Dr. Snehata Verma, ma'am. I would now request Dr. Sumit Khan Jha, sir, to kindly serve as a chairperson for this talk. Dr. Snehata Verma, ma'am, she
owns a fellowship of UPDA. She's a fellowship of IACM. She's a co-opted member of UP RSSDI. She's a member of the organizing committee of DTON 2021. She's a member of the organizing committee of PPCon 2022. She has served as an IGNU counselor for CCHN. She has been presented with the Young Researcher Award 2022 by INSC Institute of Scholar. She is a co-editor of Punarva, that is a Hindi journal. She is an editor of Interactive International Publishers. She is a member of RSSDI, UPDA, IACM, IFP, IPF, API, NMO, Indian Society of Chronomedicine, and Indian Society of Hypertension. She has written several chapters and articles in IACM, BPCon updates, and GDF. She has written various original articles that have been published in national and international journals related with yoga, diabetes, hypertension, obesity, COPD, HIV, thyroid, and vector-borne diseases. She has organized various CME awareness programs, health workshops, and rallies. I would now request Dr. Snelata Verma ma'am to kindly introduce and welcome the speaker of this session, Dr. S.P. Sondhi sir, who would be presenting a case-based approach from his vault of diabetic ketoacidosis.
For the kind introduction of mine, and Dr. S.P. Sondhi sir is no introduction. We have seen the origin of the sir. I welcome sir for your lecture today.
Thank you. That saves time. That saves time. Can we have the first slide, please? Do we have the? Yes, sir.
Second.
So this topic is very close to my heart because, I think that if we know the management of diabetic ketoacidosis, we are expert in many aspects of critical care management. Well, as a doctor, our job is to know the truth. So let's know the truth, because today there are a lot of untruths going on with artificial things. Okay, so we start with this case. A 55-year-old business executive, non-smoker, but consumes alcohol twice a week, is known type 2 diabetic with irregular treatment. His last blood glucose was done about 2 months back, which was 250. He is presented with pain in abdomen and vomiting for 2 days. Patient is drowsy. Pulse is 110 per minute. BP is slightly on the lower side, 100/66. There is generalized abdominal tenderness. Temperature is normal. His blood glucose was found to be 340. His counts was 16,000 with polymorphs 76. His creatinine was found to be 1.6. Urea was 70. Sugar was present. Ketone was present. So not a difficult case to diagnose. It is diabetic ketoacidosis. And as the name indicates, it should have 3 things. 1, uncontrolled diabetes. 2, ketone production, higher ketone production and ketosis. And 3, acidosis. And when these 3 things are combined, we call it diabetic ketoacidosis. The only thing we should remember nowadays that once we are using SGLT2 inhibitor in type 2 diabetes, we could have euglycemic ketoacidosis, that the blood glucose is nearly normal. What is nearly normal? We really don't know. Some say less than 250, some say less than 200, but that's nearly normal. So in a nearly normal diabetes, if the patient has ketoacidosis, he could be a patient of euglycemic ketoacidosis. If we look at separately at this, if the patient only has ketosis, there could be alcoholic ketosis, there could be starvation ketosis. If the patient only has hyperglycemia, It could be hyperosmolar, hyperglycemic state, etc. If the patient only has acidosis, there are so many causes of acidosis. But once all these three things together have, then we call it diabetic ketoacidosis. Well, what is the pathogenesis? Of course, there has to be deficiency of insulin. We all know that we require a minimal amount of insulin to prevent ketoacidosis. We require a larger amount of insulin to bring down the blood glucose level, but we require only very little. And most of the type 2 diabetic patient has that very little insulin in it, and so they do not go into diabetic ketoacidosis. But when they undergo a stressful situation, they require more insulin, and that little insulin becomes too little. So relative deficiency of insulin in type 2 diabetes during the stressful period can precipitate diabetic ketoacidosis. And so the concept which we carry in mind that only type 1 diabetes will have ketoacidosis and not type 2 is wrong. Many of our patients whom we see in our wards will be type 2 rather than type 1. In any case, type 1 diabetes only makes up around 5 to 10% of our total diabetic population. So we will see more patients with type 2 diabetes having ketoacidosis. So one is, that means deficiency of insulin. And two is counter-regulatory hormones have to go. Both these things contribute to diabetic ketoacidosis, not just one. Because then insulin glucagon ratio goes topsy-turvy, and that causes ketoacidosis. We'll go into basic things. There are three kinds of acetone bodies. One is acetoacetic acid, other is beta-hydroxybutyric acid, and the other is acetone. If you look at that, the true acid is beta-hydroxybutyric acid. This is a true acid. And in any diabetic ketoacidosis, this is the one which is in the largest quantity. Unfortunately, we cannot measure it in urine. So when we are measuring urine, we are not measuring beta-hydroxybutyric acid, which is the largest part of our ketone bodies. And so blood ketone level is much more reliable than urine ketone level. And then we have acetoacetic acid, which is converted into acetone. And this acetone we can smell. And please smell acetone definitely twice or thrice in a patient, because you should have that smell. I remember in my earlier first year of practice being called to see a young patient, fever, a young boy of around 30 years of age, a son of a lawyer, somewhere in Tilak Road. And I remember going to their house, seeing that patient. He says the patient ko bukhar chal raha hai पिछले 10 दिन से, and patient ठीक नहीं महसूस कर रहा, drowsy सा. When I entered the room, I could smell ketone. And so that power of smelling ketone actually I made the diagnosis of ketoacidosis, and he was diabetic, and nobody knew about it. So please smell ketone, and then you'll be remembering it for all your life. So acetoacetic acid is measured by nitroprusside. Acetone slightly measured by nitroprusside, but mainly in the smell. And beta-hydroxybutyric acid not measured by nitroprusside test in the urine, but it is the largest constituent of ketone bodies. We should remember that some drugs like ACE inhibitors, like captopril, etc., they can cause a false positive beta nitroprusside urinary reaction. Body tries to buffer this higher amount of acid present, and because body can only work in a very narrow pH, and if the pH goes up and down, the body wants to bring it back to nearly normal level. So the pH will go down from 7.3 lower down, and the lower the pH, the worse is the prognosis. If the pH is less than 7, you are dealing with a very, very serious case, and the patient has higher mortality. So we should remember that. Of course, bicarbonates will be less because they have been used up. We should differentiate between ketosis and ketoacidosis. Ketosis means there is slightly higher than normal level of ketone in the blood, and it is not yet large enough to cause acidosis. So there is no acidosis, there is higher ketone formation. And right now, in many of the keto diets, we are promoting that. Low carbohydrate keto diets actually increase the ketone level in the blood, and that cause a little bit of nausea, loss of appetite, and that they welcome because they have lost the appetite, so they can diet more vigorously. Another physiological condition which sees ketosis very frequently is pregnancy. Especially in the third trimester of pregnancy, ketosis is very commonly present, higher ketone body, but it's not ketoacidosis, right? So we have to differentiate the two. Right, this we talked about, that nowadays we could have a euglycemic ketoacidosis because when we use SGLT2, they decrease the blood glucose. When they decrease the blood glucose, the insulin level comes down and glucagon goes up. All of us know that using SGLT2 inhibitors for long increases the glucagon level. So insulin comes down, glucagon goes up, and that's what causes ketosis, even when the blood glucose is nearly normal. Well, diagnostic testing, we all know that the glucose can be high. The lower the pH, the worse the prognosis. Lower the bicarbonate, the worse the prognosis. And the urine ketone and osmolality will be variable. I won't go into the details of it. Right. What are the common precipitating factors? Some of the more common risk factors which can precipitate is infection, non-adherence to insulin, acute major illness like myocardial infarction, sepsis, pancreatitis, stress, trauma. In this patient, the triglyceride was 1,100, amylase was 850. He had pain in abdomen and vomiting. Is it pancreatitis? So that's the question, because we all know that when there is lower insulin level and higher glucagon level, the breakdown of fats is more there, and it is broken down into free fatty acid, which is, some of it is converted into triglyceride. So triglyceride level goes up in diabetic ketoacidosis. Some of it gets converted into ketone bodies, and so ketone goes up. So higher triglyceride is very frequently seen in diabetic ketoacidosis. Now, this patient has been on alcohol also and has pain in abdomen. Amylase is high. Is it pancreatitis? So we should remember that diabetic ketoacidosis, the serum amylase can go up. Most of these amylase is parotid one, not the pancreatic one. And so we should do a serum lipase level to be more specific, or of course CT abdomen. But even without CT abdomen, if we get a serum lipase done, serum lipase level is high, it is likely to be pancreatitis. If it is not high, it's not pancreatitis. It is a part of diabetic ketoacidosis. And this we have talked about. Serum lipase in this case was normal, so we were not dealing with a case of pancreatitis. Possible cause of abdominal pain and vomiting in diabetic ketoacidosis is acidosis. Acidosis causes delayed gastric emptying and ileus, and that causes pain in abdomen and vomiting. The patient loses water, the patient loses sodium, the patient loses potassium, phosphate, magnesium, calcium, etc., etc. And we got to remember that hyperglycemia causes osmotic diuresis with severe fluid loss. The fluid loss could be as much as 5 to 7 liters in a typical patient. Now, in this patient, the pH was 7.1, bicarbonate was low, sodium was 144, potassium was 3.3, and 1 was 50. So now we got to remember that whenever there is high blood glucose, the osmolality of the blood is high. So what will it do? It will suck the water out of the intracellular compartment. The water from intercellular compartment will shift out into the blood. And this water will bring down the sodium level. So you got to correct the sodium level. For every 100 gram higher than 100 reading, you got to add 2 milliequivalent to whatever you're getting. If you're getting serum sodium of 130 and the blood glucose is 400, then add 6 to it. and that is a corrected serum sodium. So please remember this correction. But at the same time, this patient must have lost sodium. So one of the lessons to learn here is that serum sodium and serum potassium level does not indicate total body sodium and total body potassium. Please remember this. Here in this case, total body sodium is low, but because of massive diuresis, etc., the blood has become concentrated and the sodium level is showing falsely high. So serum sodium level is a sodium in relation to water. It does not indicate total body sodium. And similarly, serum potassium does not indicate total body potassium, because potassium is basically an intracellular ion. It remains inside the cells, and shift of potassium in any situation will alter the serum potassium level, not reflecting on total body potassium level. I give you example. Whenever there is acidosis, the pH goes down. That means there are H ion concentration is very high. Now body wants to buffer these H ions. So where will it shift? Half of these H ion will be shifted inside the cell. And when the H ion will be shifted inside the cell, potassium has to come out to maintain the electroneutrality of the cell. So in any acidosis, potassium will shift out of the cell, which will increase the serum potassium level. Because what you are measuring is serum potassium, not intracellular potassium. And this intracellular potassium is now shifted out. This is one of the basic things one should understand, because this will be handy to you in many critical situations. I'll tell you how it will be. Does he require CT head for diagnosing the cause of drowsiness? Because he is drowsy. And does he have a infarct? Does he have something else? Well, there is a clinical clue. So this is the diagram I made. When the osmolality goes up in diabetic ketoacidosis, when the blood glucose is high, the osmolality goes up. When the blood osmolality goes up, the water moves out of the brain cells and the brain cell will shrink. And because of the shrinkage of the brain cells, the patient may become drowsy. Now, after some time, the brain cells starts producing their own osmoles, which may not be enough, but they start producing their own osmoles. They don't want to become totally dry. The total water should go out. And once you treat diabetic ketoacidosis and the osmolality is rapidly corrected, don't correct the osmolality rapidly, because it will do the reverse. The water will shift inside the cells, inside the neuron, because the inner osmoles which you are making take few hours to bring down. So please take, these are very, very important lessons of critical care here, right? So because of higher osmolality in diabetic ketoacidosis, patient can become drowsy. How will you correlate? The correlation is, you will calculate plasma osmolality. The calculation is very clear, 2 into sodium upon glucose upon 18 and 1 upon 2.8. And normal osmolality is about 275 to 295. And this is a very, very important chart, which tells you that if the patient becomes drowsy, the osmolality has to be around 310, 20 or 325. So if you calculate plasma osmolality, and plasma osmolality is about 300, and still the patient is drowsy, there is some other cause. You have to get a CT or an MRI done. So correlate osmolality with the drowsy status, and that's very important. Does high TLC in this case indicate infection? No, because leukocytosis is usually present because there is hemoconcentration. So a count of 16, 18,000 really doesn't matter. It will be, they say either it should be more than 25,000, and then you can diagnose infection in a diabetic ketoacidosis, otherwise not, or they should shift to the left. So please remember that. Now, what is our priority? We have to give fluids, we have to give insulin, we have to give electrolytes. Our priority, number one, is fluids, because just giving fluids restores the intravascular volume. A patient of diabetic ketoacidosis comes to you with a 500 blood glucose and you give just normal saline. His blood glucose will come down to 300, 400 just without giving insulin. Two, it restores kidney functions. And three, insulin has to wait. You have to not to start insulin immediately because you must know potassium level. I just told you that correction of acidosis by insulin will push potassium from outside the cells to within the cells. And so serum potassium is likely to drop. So you must know what exactly is the potassium, because you can kill the patient by bringing down the potassium level to around 2.5 or something. So which fluid should be given? So that's why I love this diabetic ketoacidosis, because it tells you the basics of critical care management. And this is a very old medical clinics in North America, which I used to subscribe very regularly when I became doctor. And I kept on subscribing for about 20, 25 years. But then, everything became available on, internet and Wi-Fi. And so in one of these, this is a fantastic diagram, which I've taken from January 1995 endocrine emergency issue. And it tells you this is the normal. Intravascular compartment, interstitial compartment, intracellular compartment. This is the fluid in the body. When diabetic ketoacidosis occurred, the intracellular compartment has shrunk, the interstitial compartment has shrunk, the intravascular compartment has shrunk. All compartments have shrunk. Now, when you give isotonic saline, it expands intravascular compartment to nearly normal. It expands interstitial compartment little more, but the intracellular compartment is still dry. If you want to expand intracellular compartment, you have to give N/2 saline. So we start with normal saline, and after some time, we are better off in giving hypotonic saline. If you want to expand, if you give colloid, it will expand intravascular compartment much more than anything else, right? So please remember this. I'm not going to talk about which is what this you are being taught everywhere, which is a normal tonic and which is hypotonic, and what are the concentration of these fluids, sodium, potassium, etc. So when to start N/2 saline after normal saline? After a few hours to satiate intracellular compartment, we can shift to N/2 saline. When sodium is normal or elevated, we can shift to N/2 saline. When potassium replacement is the priority, as K is osmotically active, so if we add potassium to normal saline, the osmotic level goes up, and that is what it is. Ringen lactate was found to be no better than normal saline in bringing pH to normal. It took more time to glucose levels. So I think the first fluid to be given remains normal saline. And of course, if you look at that, you don't give bicarbonate till the pH is 6.9 or less. You are allowed to give bicarbonate only when the pH is 6.9 or less. Above that, you are not to give bicarbonate. Insulin should be given only if the potassium is less than 3.3. And this is a serum potassium. And this is the potassium after shifting of potassium from intracellular compartment to outside. So this 3.3 is very low level. So you have to hold insulin. Don't give insulin till you bring up the potassium level, because if you give insulin before bringing up the potassium level, the potassium is going to be catastrophically down and the patient can have arrhythmia and die. So that's very, very important. And when the potassium is around 3.3 to 5.2, you keep on giving potassium. So even when the potassium is normal, you are giving potassium. Only when the potassium is too high or the kidneys are not functioning well, that you stop giving potassium. I will not go into the details of it. So again, saying the same thing for dehydration fluid, for potassium, you replace potassium, and if the potassium is less than 3.3, again saying no insulin, and same is true of acidosis. Insulin, we have already talked, that delay insulin if the potassium is less than 3.3. You have to give regular insulin, long-acting insulin not to be started. The point is, what we repeatedly do. Excellence then is not an act, but a habit. The point is that if you keep cutting corners in treatment, you will never remember what is the exact treatment. And this is what happened to me about, I was into my practice 2-3 years and I got a case of diabetic ketoacidosis. And that lady's husband told me, sir, do the best for my wife. And I had forgotten what was the best, because I was not getting pH done repeatedly done in a clinical practice. I don't know how frequently should the pH be repeated. I had forgotten the best. So that's what happens to us when so keep it a habit. Even if your patient is not able to afford it, you must write it down on the case sheet that this is required. So what is the monitoring? Well, you have to blood glucose initially hourly, then 4 hourly, electrolytes 2 hourly, and then 4 to 6 hourly, pH 2 to 4 hourly. So the pH initially has to be done very frequently to know whether you're going in the right direction or not. But you will ask me, arterial blood gas, how can you take it very frequently? It's not easy. You don't have to. For pH, you don't have to do arterial blood gas. You can rely on venous blood. And there is just a difference of, 0.1 or something. Arterial blood gas rarely influences. So venous blood gas is 98% sensitive, 100% specific for diabetic ketoacidosis. Venous pH is approximately 0.03 lower than arterial pH. So just add 0.03 to your venous pH, and venous pH is easy to do. Do it every 4 hourly. Expected recovery time, blood glucose comes down at 80 milligram per hour. So from 500 to 200, it'll take approximately 4 hours. If it is taking less, increase the amount of insulin, because some people may be very resistant to insulin. It takes twice the amount to reach normal for bicarbonated pH. So pH and bicarbonate will take about 10 hours and maybe 12 hours. And urea creatinine will come down by hydration only. As soon as they are hydrated, urea will come down. Creatinine will come down. So, dear friends, in a nutshell, diabetic ketoacidosis is an excellent emergency to learn critical care management. We must remember, and I keep emphasizing it, that serum sodium level is not reflection of total body sodium. Your total body sodium could be low and serum sodium could be high, because the patient has lost more water than sodium. Serum sodium level is sodium in relation to water. It's almost like I give you a pinch of salt and ask you to dilute it in about 1 liter of fluid or in 5 liters of fluid. The sodium level will be different. So almost that. And similarly, potassium level does not tell you about the total body potassium. It may have shifted out or may have shifted back into the cells. That's very important. And you have to choose according to the goals in mind. What do you want to do? If the blood pressure is too low, you will choose either colloid or normal saline. But once the blood pressure is fine and you want to expand the intracellular compartment, you may give N/2 saline. And be clear about osmolality and its effect on brain. Because even in treatment of hyponatremia, this will come handy. If you treat hyponatremia very fast, you will cause damage to the brain. So this is the nutshell. This, I think. Thank you very much. Any questions, comment? I think this is one critical care management which you are doing. All of us are doing very frequently in a clinical scenario.
Thank you, Soni sir, for briefly and nicely describing each part of the management of diabetic ketoacidosis, role of pacing and management of electrolytes. And basically, as you have told that we have to focus first on the IV fluid arrangement. We have to restore the hydration, maintain the hydration of the patient. Many of the times we have encountered such patients that they are not diabetic. They are not, and even they diagnosed first time diabetic when we saw the clinical history and have taken the clinical history and measured the blood glucose and green keto. They are found that they are diabetic. They never, patient even not bother about their status. And these type of patients we are clearly encountered. So one question from my side is there any role of sodium bicarbonate in these patients?
Well, I talked about it in a very brief, no. If the pH is more than 6.9, it will causes reverse changes in the CNS. So paradoxic changes in the CNS. So you should not give soda bicarb if the pH is more than 6.9. Very clear indications. There could be problems with it. So if the pH is less than 6.9, then you are allowed to give soda bicarb. That's a very critical situation, not otherwise. The acidosis will come down once you start giving insulin. The acidosis will come because it is basically the insulin absolute deficiency or relative deficiency of insulin which is causing this. So as soon as you start giving insulin, as I said, the pH within 10 to 12 hours will come down to, will start coming down.
Thank you, sir. Thank you, sir, for the presentation. Sir, a few questions from my side. We are living in a country where patients prefer OHA. Many times patients recover from BK and they insist in a major tablet data. So when should we start or restart OHA these patients?
Well, you're right. Many of the type 2 diabetes do fine till they are in stress and then they go into diabetic ketoacidosis. So after the ketoacidosis is finished, you can, and the patient has started eating, you can give him subcutaneous insulin and discharge home. And then maybe after a month or whatever time, you decide whether this patient will do good on OHAs or not. Because many of the type 2 diabetes, which we think are type 2 diabetes, are actually LADA, latent autoimmune diabetes of adults. And they have severe insulin deficiency. So you will have to rule out a severe insulin deficiency before switching these patients totally from insulin to OHAs. So I'll be very keeping my fingers crossed that they are not LADA. If they are LADA, you will have to keep them on insulin for lifelong. But if they are not, and their insulin level is pretty reasonable, then you can gradually shift after some time. But you got to be careful.
Any more questions from the house? Anyone? PG students?
Thank you, sir. The way you constructed the lecture and explained the intricate concepts with such clarity was commendable, sir. I would now like to request Dr. Saurabh Singhal, sir, to thank the speakers, Dr. SP. Thank the speaker, Dr. SP Sondhi, sir, with a memento and a bag. एक लकी ड्रॉ Dr. Sondhi, sir, while you are still here, I would like to request you to pick up a lucky draw from the box and announce the winner. Reverse.
Dr. KM. KM.
Mukti. Okay. He is not here.
Dr. Sandeep Kansal sir's dedication to advancing the understanding and treatment of cardiovascular diseases has made sir a respectable figure. Dr. Sandeep Kansal sir's dedication to advancing the understanding and treatment of cardiovascular diseases had made sir a respectable figure in the medical community. With a wealth of knowledge and a commitment to patient care, Dr. Sandeep Kansal sir will guide us through the insightful discussion on acute coronary syndrome, shedding light on its intricacies, latest advancements in treatment, and the critical importance of timely intervention. Without further ado, please join me in welcoming the chairpersons on the podium for this talk. Dr. Varad Gupta sir, Dr. Varad Gupta sir. Dr. Varad Gupta sir did his MBBS in 1989 from LLRM Medical College, Meerut. He did his MD in 1992 from LLRM Medical College, Meerut. He did his DM from KGMC, Lucknow in the year 1999. He's an ex-professor of medicine in Subharti Medical College. He's an ex-professor of medicine at Bhatnagar Medical College. He has done various paper presentations on National Conference of Cardiological Society of India and international conferences. He is a fellow of European Society of Cardiology. He is currently practicing as an intervention cardiologist at Metro Heart Institute for the last 20 years. Welcome, sir. Next up, I would like to invite Dr. Amit Sharma, sir. Dr. Amit Sharma has worked as a senior resident in the Department of Cardiology in PGI MER and Dr. RML Hospital, New Delhi. He's an associate consultant in cardiology, Max Super Specialty Hospital, Shalimar Bagh. He's the head of Department Cardiology at Subharti Medical College. He has started 2D Eco course in Subharti Medical College. He has done multiple poster and paper presentations in the field of cardiology. He has published multiple papers in reputed journals. He has done more than 100 CMEs. Welcome, sir. Next up, I would like to invite Dr. Amit Kumar Jain, sir. Dr. Amit Jain has done his MBBS from Medical College, Baroda in the year 2001. He did his MD from NHL Medical College, Ahmedabad in the year 2006. He did his DM in cardiology from KGMU, Lucknow in the year 2010. He's a member of Cardiology Society of India, API and RSSDI. He is a fellow with the American College of Cardiology. He has presented various papers in national journals. He has previously worked as a consultant in Metro Hospital and Heart Center, New Delhi. He has worked as a head of Department of Cardiology in KMC Hospital, Meerut. He is currently working as a head of Department of Cardiology and a cath lab. He's in charge of Sai Hospital and Critical Care Center in Meerut. He has a special interest in heart failure management and arrhythmias. I would request Dr. Amit Kumar Jain, sir, to kindly come forward and introduce our speaker for this talk.
I invite Dr. Sandeep Kansal, sir. He is a consultant cardiology professor and former head department of cardiology, Bhatnagar Mahoy Medical College and Switzerland Hospital in Delhi. He was physician to the former Prime Minister, currently on board several government bodies like Technical Expert Group of Government for Energy Revolution, Drug Controller General of India, Cardio-Renal Expert Panel, New Drug Advisory Committee, Medical Device Advisory Committee. He is the Department of Biotechnology, Bioengineering Task Force. He is the Department of Science and Technology, Science Engineering Research Board, Department of Health Research, Member of Committee for Medical Research Unit. He has contributed papers published in various journals, 21 chapters in books. He was editorial associate in Indian Heart Journal, on editorial board of GIM-SA. He is a reviewer for International Cardiology, International Nephrology, and many other representatives. He wrote editorial for International Cardiology. With this brief introduction, I invite Dr. Sandeep Kansal for presentation on the initial management of kidney.
Left and right. Good afternoon and thank you, chairpersons. It just happens that most of us are from King George's. I did my DM in 95. Varad was 2 years my junior in 97, and then you were there in 2010. So it's a pleasure, and I have a special place in my heart for Merit because my DM entrance was held here way back, almost 30 years ago in 1994. So thank you for having me here. And as the topic says, acute coronary syndrome initial management. Now, what do we really mean by initial management or early management? So broadly, you can, I mean, it's kind of arbitrary, but by and large, by the time the management of a patient, by the time a patient gets to a hospital, is very early management. You get symptoms, what you do you call an ambulance? Do you go by your own self? Or do you take any medicines? All that is very early management. Early management or initial management can be classified as, again, arbitrarily, as management of the patient before he is given a definitive therapy for an acute coronary syndrome. And as we all know, the therapies in acute coronary syndrome are, number one, thrombolysis in cases of ST elevation MI, percutaneous coronary interventions or coronary angioplasty, as we know of, and a mix of the two that is called the pharmacoinvasive therapy. So from the time that the patient comes to you till the time he goes for a definitive therapy in the form of reperfusion or undergoing PCI, that is actually the early management. And in majority of the cardiology conferences that we go to these days, most of the times you will find people show you 20 plus angioplasties that they did in past some time. I'm not going to bore you with that. We'll just talk of basic science as I would like to teach my students in my place. So the first thing to remember is that the definitions in coronary artery disease are changing. From what we know, we used to have a condition called chronic stable angina because we believe that a patient gets angina, it's a low mortality entity. From that, the European Society of Cardiology now talks of only two syndromes. One is the chronic coronary syndrome, and the other is acute coronary syndrome. Chronic coronary syndrome is a heterogeneous group. It is not a less than 4% per year mortality group, as we used to call chronic stable angina. Based on the clinical features, based on the accompaniments like presence of diabetes, hypertension, family history, smoking status, the chronic coronary syndrome also can be a heterogeneous group. And the highest group, say, imagine your patient is a diabetic, your patient is a young male, say about 50 years of age. He's got chronic kidney disease along with that. He's also a hypertensive, he smokes and has a family history. Such a patient, even if he has a stable angina, he will have a mortality of approaching up to 10% in a year. So that you have a heterogeneous group in the chronic coronary syndrome. However, what we are talking of today is acute coronary syndrome. How does acute coronary syndrome occur? Now, if we look here, this is an atherosclerotic plaque, and the atherosclerotic plaque keeps on growing up as more and more cholesterol gets accumulated inside it. We also know that in a atherosclerotic plaque, there is a covering. There is a covering and there is a lipid core which is inside that. Now, if the covering over the atherosclerotic plaque is thin, or the lipid core is very massive, forming more than 40% of the total plaque, or the cap is very thin, what we call as thin cap fibroatheroma, then these plaques have a tendency to rupture. Okay, acute coronary syndromes are caused by three major phenomena. One is the plaque rupture. That means the surface of the plaque bursts open and suddenly all the contents which are lying inside the plaque, they are exposed, the blood is exposed to them. And within a matter of minutes, the clotting starts, the platelets first start to adhere and then they start to aggregate and you have a white thrombus formation there. Over a period of time, RBCs also get there. A lot of other factors are released, and we find a red thrombus in ST elevation MI. So plaque rupture, when I was a student, DM student, we were told that 90% of the 90% of these acute coronary syndromes are caused by a plaque rupture. However, we now realize that you really don't need a plaque to rupture, burst open, and the materials to come in over there. You can just have a simple erosion of the plaque, and then this is enough to cause acute coronary syndromes. The third thing that is going to cause it is a calcium spicule. We know that we call these as complicated plaques. There may be a calcium spicule which is jutting into the blood vessel, and even that can cause an acute coronary syndrome. So the redistribution in the present time is that almost 60% of the plaques are actually caused by a plaque rupture. About 25% of them are caused by a plaque erosion, 20 to 25%, and 5 to 10% are caused by calcific spicules. Now, imagine that the plaque has ruptured. There is a clot which is formed there. The body, as we all know, has its own endogenous thrombolytics. It has its own ways to counter it. So imagine there was a blockage which got relieved after some time. What do we get? We get unstable angina. The blockage was prolonged for a certain amount of time to the extent that some amount of myocardium is damaged, but it is not, the wall is not being completely taken off, means it is not completely dead. We get non-ST elevation MI. And if we have a persistent blockade which extends over an hour, over an hour or more, then we get what is known as ST elevation MI. So these are the typical changes that are being shown there. So the ECG is normal in a normal patient, mostly in stable angina patients. In unstable angina, you may have normal ECG or you may have non-specific T inversion or ST depressions. In ST elevation MI, you typically have an ST elevation. Now, why this is important is I've taken a lot of my slides from the European Society of Cardiology guidelines, which came in about a few months ago, about 3 months ago. This is to ensure that we go in a systematic manner, just as the young doctors should be taught. It is also in an effort not to miss anything and also to keep a distribution of the thought process. So the first thing that the patients we need to know about acute coronary syndrome is that it encompasses a spectrum. The spectrum can be unstable angina, as I said. It can be non-ST elevation MI. It can be ST elevation MI. Please also remember that sometimes when we get a patient with persistent ventricular tachycardia. That also is a sign of ischemia. It is also a sign of ischemia, mostly a myocardial infarction. And the fifth and the most sinister, and unfortunately, most of the patients fall into this category, is sudden cardiac death. We all study that 50% of patients who have myocardial infarctions do not reach the hospital. It is these patients who have sudden cardiac death. So, in medical books, you no longer find the mention of ventricular tachycardia or sudden cardiac death as a manifestation of acute coronary syndrome, but that's the way it is. So when the patient comes to us, the first thing is to do the ECG. While we are doing the ECG, we talk of the clinical history and we see whether the patient had a previous stable angina or not. Then we plan the strategy. What will be my strategy? Does this patient need to go to an invasive arm, which means urgently the patient needs to undergo a coronary angiography, or the patient needs to go to a non-invasive arm? We need to categorize the antithrombotic therapy for these patients. Then we need to see how we are going to revascularize, and finally, the secondary prevention and discharge. So let me go further. So this is what I was talking about. The two most important things in the management of an acute coronary syndrome are, number one, the diagnosis, and number two is the strategy. At the time that your patient presents to you, within a short while, you should be able to plan the strategy for your patient. The most important thing in terms of the diagnosis is ST elevation MI. And why do I say that? Because ST elevation MI is a necrotic, it is a time dependent phenomenon. The time here is extremely important. The slogans that we hear in the press, in the media, from the government, time is muscle, seconds save life. All this is in relation to ST elevation MI. Not that non-ST elevation MI is not important. We need to understand that if we consider mortality at 1 year, the mortality is almost similar, maybe very slightly higher for ST elevation MI. But in non-ST elevation MI, there is a catch-up phenomenon. The importance lies in the fact that if my patient has ST elevation MI, no matter how, you need to revascularize these patients. You need to open up the artery. You need to, restart the flow. And that is the most important thing. If my patient has ST elevation MI and he has presented to a center which is PCI capable, I should be able to do the PCI within 90 minutes within 90 minutes of the patient arriving in the center. If the patient has come to a non-PCI capable center, this limit is 2 hours. The important thing to understand is that analysis have shown that if you have, say, a patient has come to me right now and I see this is ST elevation MI, I have to quickly determine, will I be able to send him to a place which is PCI capable? And it just does not mean the patient came here, my cath lab right now is not open. Should I send him to Varat? Varat has to be there. The doctor treating there has to be there. It is not just that you send the patient. You have to talk to the concerned doctor. I'm sending you a patient. Will you be able to handle him? So we have to be able to do that. If the delay is beyond 120 minutes, the benefit of PCI is lost. In such a patient, you better thrombolize. Good old thrombolysis, whether you use streptokinase or you use tenecteplase or you use retaplase, preferably tenecteplase because it is easier to give by the residents. So I distinguish ST elevation MI from all other phenomena. So first thing is, for another important thing to remember is for ST elevation MI, you don't need enzyme for the diagnosis. The diagnosis is already made if my patient has chest pain, which has been lasting for more than half an hour. He has associated features like diaphoresis, like vomiting many a times. So ancillary features with the chest pain of more than half an hour, with ST elevation or a new onset left bundle branch block. Two things: ST elevation in at least two contiguous leads or a new onset left bundle branch block. These are ST elevation MIs. Immediately your mind is clear, all right, this patient has ST elevation MI, I have to expedite everything. The non-ST elevation MI patients, they give you generally some bit of time to think, time to risk stratify, time to see what kind of therapy you're going to take. So if my patient has non-ST elevation MI or even ST elevation MI, I, I would decide the therapy. I would also do some bit of imaging. The echo has an advantage that it is so easily available. It can be moved to the bedside. You can at least rule out important complications. Sometimes complications like a mild mitral regurgitation, like a ventricular septal rupture, like a mild pericardial effusion, they may not be clinically, possible to be diagnosed, but they are extremely simple and easy on echocardiography. You're also able to make out the amount of ejection fraction, because that is dependent upon how much of myocardium is at, that also is an indicator of how much myocardium is at risk. So do echocardiography and then categorize your patients. If there is no ST elevation, but the enzymes are raised, non-ST elevation MI. If there is no ST elevation and the enzymes are also not raised, but the patient is having chest pain, the patient has unstable angina. And if none of them is there, a non-ACS angina. So you, even such a patient, you observe for a certain period of time. If the ECG changes do not take place at all, remember, initial ECG can always be faulty. It can be absolutely normal. It can have non-specific abnormalities. So you need to keep the patient, what we call as triage the patient, keep the patient for some time, do repeat ECGs and do blood tests in case it is a non-ST elevation MI or an acute coronary syndrome broadly. Then you can, after, it is only after say about 12 hours that you can say for sure that this patient does not have an acute coronary syndrome. There are faster ways also. There are faster ways, as in if my patient has chest pain, the ECG is normal. There are now high sensitivity troponins that are available. What is the difference between the conventional troponins that we do and the high sensitivity troponins? Remember, there are 2 or 3 ways in which these troponins are measured. One is the card test. We all know of certain card tests. You put a drop of blood there, a measured drop of blood, and if 2 lines appear, that means the card test is positive. And many times you get patients referred that the troponin is positive. They don't give you the value, but they give you the level, the positive or negative. This is semi-quantitative. It generally means that the troponin level is more than 0.09. It is more than 0.9. That means it is 1 nanogram or more. 1 nanogram per milliliter. So what is the unit of the standard troponins? It is nanogram per ml. Now, if I make it 1,000 times more sensitive, nanogram in 1 liter, I've increased the denominator 1,000 times. I'm able to detect that nanogram in a liter of blood. Then it becomes highly sensitive or high sensitive troponin. Please remember that even normal people, you and I, and we've come out in a cold weather, or we have some amount of stress, we have done a lot of gymming this morning, the troponins can still be high. So high sensitivity troponin suffers from a drawback that there are cutoffs available. If the high sensitivity troponin is less than 14 nanograms per liter, 14 nanograms per liter, then perhaps the patient is all right. But the initial value of troponins can be normal in majority of the patients. The negative predictive value of troponins is only present after 11 to 12 hours. The second way is that you do the initial troponin, and there are protocols available. What is called as 0 and 1 hour protocol, 0 and 2 hours protocol, 0 and 3 hours protocol. This is particularly for emergencies which are flooded with the patients, and you have to rapidly triage them. So if my level was normal initially, but rose in the first hour by a certain percentage, or rose by 2 hours by a certain percentage, then I know that this patient is an acute coronary syndrome. If my patient's troponin hasn't risen by about 12 hours, I can, with a 97 to 98% sensitivity and specificity, rule out an acute coronary event. In such patients, we advise them to undergo a stress testing within 72 hours approximately. Generally, within 3 days, we should do reversibility testing, do a treadmill, do a stress thallium. That is how you approach such patients. So this is the algorithm which is given for patients who present with ST elevation MI. So if the patient comes to a PCI center, then the patient undergoes a primary PCI. If the patient comes to a non-PCI center, can I be able... So another important thing is, as soon as the patient comes, within less than 10 minutes, we should be able to do an ECG in these patients. When I entered King George's, I did a project on giving rapid streptokinase. And my time of arrival at door to getting the ECG done was 9 minutes. It was because we were a fantastic center. We were a catchment. We had a huge catchment area. There was no place other than King George's in Lucknow which used to cater to cardiology emergencies at that time. So, but they were fantastically equipped, as in there would be a DM resident posted there 24 hours a day and would do ECG in no time and thrombolize those patients in a jiffy. Door to needle times of about 11 minutes, door to ECG times of 8 to 9 minutes. Those are fantastic figures. So this, we need to ensure that our patient does not have to wait for more than 10 minutes once he comes to the emergency. If I'm not a PCI capable center, then I go to the fibrinolysis arm. The important thing is that from the time the patient develops symptoms to the time reperfusion therapy is started is the total ischemic time. Most important reason for delay is what Dr. Sodhi covered in his first talk, self-denial. We keep on denying ourselves, मुझे तो heart attack हो ही नहीं सकता, मैं तो fit बंदा हूँ, I don't have any problems. So the denial, then they start saying gas hogi, and this is the commonest delay. In fact, I was in a meeting with the ICMR guys, and the chairperson said, what do you suggest is the most effective way in primary prevention? I said, you take the help of Amitabh Bachchan. He said, how? I said, when he can tell, take care of your blood sugar, get the diabetes diagnosed. Why not? Why doesn't he talk about people, telling people that if you have a chest pain, err on the side of overdoing it rather than underdoing it. At worst, what will happen? The patient will come to Subharti, the doctor will see here, he will do an ECG, he will do a repeat ECG after an hour or two, do the enzymes and say you're normal. That's it. There's nothing more than that. But if you have a heart attack and you keep on denying yourself, you miss out of the golden period. If the patient has non-ST elevation MI, again, we need to see whether the patient has come to a PCI capable center or not a PCI capable center. If the patient is a very high risk patient, now what are very high risk patients or high risk patients? For that, we have to measure their blood pressure. Patients who have cardiogenic shock, patients who have additional heart sounds other than S1 and S2. If my S1 is muffled, I have mitral regurgitation. If I have an S2, which is wide split, then I have an RBB. So I have a RBB myocardial infarction, very high risk group. If I have a S4, I put the stetho on the chest and I find that there is a fourth heart sound heard. It means that 8 to 10% of myocardium has already been damaged. If I hear a S3, more than 20% of my myocardium has been damaged. When I auscultate the chest, if the crepitations are present in the lower, less than lower 1/3, then I have about, again, 20 to 25% of my myocardium which is damaged. And if I am in cardiogenic shock, then more than 40% of my heart is gone. So clinically, you're able to risk stratify these patients. Patient who's having dynamic ECG changes is a high risk patient. The simple rule of thumb in terms of ECG is if there are dynamic changes, this patient is for an early intervention. Okay. If your patient's clinical features are changing, if his blood pressure is not catching up, if he has added sounds or he has an added murmur, all these patients are high risk. If your patient's troponin is high right at the time of presentation, he's again a high risk group. So all those patients who don't have ST elevation MI but are at high risk, are at very high risk, they go to the PCI strategy. They will need a PCI. If the patients are not in the very high risk group, but on high risk group, I mean, this again can be read, but I can tell you there are, as I said, dynamic ECG changes. There are scores available. For example, the GRACE score. I'm sure all of you guys study when you study the acute coronary syndromes. So if the GRACE scores are high, then all these patients are again high risk patients. Also, you add the enzyme values that we have been talking about. So if your patient is high risk group, if he has come to PCI capable center, well, let him go for PCI. If he's come to a non-PCI capable center, then manage them conservatively. Okay, this I have already discussed. So broadly speaking, this slide I'm going to take time. Pain, we've already discussed what are the pain characteristics which tell you this is an acute coronary syndrome. The time frame is pain lasting more than half an hour. This is some important question that your faculty, your teachers are going to ask you. When do you say that the pain is suggestive of acute MI? If it is lasting for more than half an hour, if it has accompaniments, what are the accompaniments? Sweating, vomiting many a times, and the Levine sign. Can somebody tell me what is Levine sign? Okay, so the Levine sign, classically, we know loosely, all of us know. Loosely, actually, Levine sign means that when you ask the patient, this is wonderful thing in nature. When you ask the patient, where is your pain? He says, I get pain here. So if he clenches his fist and puts it to his sternum and says that I have pain over here, rather than moving an open fingered hand and saying I have pain here, it has been seen that 40 to 50% of the times, if he clenches the fist, it is likely to be a cardiac pain. If he opens fingers of the hand up and down, then it is more likely to be non-cardiac, mostly esophageal in origin or gastroesophageal problem. Okay, so that is Levine sign. Then associations we talked about, there can be pain equivalent. Patient says, कल तक तो ठीक था जी, आज शाम से सांस चढ़ रही है अचानक से. Particularly diabetic patients who've had neuropathies with them. Many times women, they don't get chest pain, they just get equivalents of chest pain, which would be breathlessness most typically. Some people actually have a syncope, they fall down. Some people may actually have bradycardias, complication of inferior wall MI. So these are the equivalents. The importance of S3 and S4 and crepitations. How do we classify acute MI? Can any one of the residents tell me the classification which is used to categorize the severity of acute MI? Please remember, it is the Killips classification. So at the time of admission, we should be able to tell which Killip class your patient is in, because Killip class will determine the in-hospital mortality, and it will also determine the one-year mortality of these patients. Murmurs, particularly if you have a systolic murmur, you need to see whether the murmur is because of MR or because it is because of ventricular septal rupture. Please remember, ventricular septal ruptures, in 80% of the cases, they die unless they are undertaken, taken up for surgery. So surgery is extremely important in those patients. In ECG, I've already highlighted the importance of being able to make out ST elevation MI versus others. Troponin I, again, we have discussed. Routine biochemistry. Remember, the total leukocytic count is proportional generally to the severity of acute MI. So you'll find that the patient has raised DLC. You're also able to make out whether the patient has chronic kidney disease or not, or at least what is the kidney status at that particular given moment. We also discussed many a times we diagnose the diabetes initially at the time of presentation of acute coronary syndromes. We do echo to rule out a lot of things, to look at which area of the heart is involved, what is the ejection fraction, because that tells us how much of damage has already occurred. In terms of treatment for pain, what do we give? Say that? Morphine, yes. So for pain, and there have been a lot of criticisms for morphine, particularly in ST elevation MI. Still, morphine continues to be the drug of choice because it is a very effective painkiller. Number two, morphine can be given intravenously. It also causes some degree of sedation and also depresses to some extent respiratory center. If the person is anxious at that time, hyperventilating, it breaks that cycle, causes a relief of pain. But the effects also bring in some side effects. It can cause respiratory depression and it can cause vomiting. So for vomiting induced by morphine, what do you give? Say that? Ondansetron is for chemotherapy induced vomiting, which is a new drug for chemotherapy induced vomiting. Say that? I'm not aware of Ranitidine, but the newer thing is actually olanzapine. Fantastic antipsychotic being used for chemotherapy-induced pain. We should ideally use domperidone in these patients because, perinom will cause extrapyramidal symptoms. So use morphine. What is the dose of morphine that you give? The dose of morphine recommended by the American College of Cardiology is 2 to 5 milligram boluses. Typically, we tell the sister, give a 3 milligram bolus. So 3 milligram boluses are given. They can be repeated fairly frequently between 5 to 15 minutes interval, depending upon the pain relief or the side effects, which will be respiratory depression or sometimes even hypotension. Can you imagine what is the maximum dose that can be given in the according to the textbook? You'll be surprised to know अफीमची भी शायद इतनी dose नहीं लेते. Up to 3 milligrams per kilogram is the recommended maximum dose for morphine. Okay. Then comes oxygen. ये मुझे who's the final year PG students? Who are the final year PG students? Do you give oxygen inhalation to all the patients of myocardial infarction? Yes or no? No. So if the oxygen saturation is less than 90%, you give oxygen to these patients, inhaled oxygen. If you give oxygen to patients who are otherwise normal, whose oxygen saturation is normal, what is the drawback? It causes vasoconstriction. Peripheral vasoconstriction, it increases the afterload, it increases the myocardial oxygen demand. What is happening here? It's a demand supply imbalance. So you improve the supply by reopening the vessel and you decrease the demand in whatever way possible. So you've given morphine, you've you've given oxygen so that the demand and supply mismatch is not there. There is a new concept which has come in last few years. Can you give oxygen in any other way to these patients of ST elevation MI? You'll be surprised to know that intracoronary oxygen, there is something called supersaturated oxygen therapy. There have been 2 trials in last 2 to 3 years in which when you're doing angioplasty, what you do is you take out the blood, the venous blood is taken out, it is mixed with oxygen in form of very fine bubbles, not as a bolus. If air goes into the artery, otherwise it is disastrous. But if you make a very fine solution in which you have mixed it with blood in a very, very fine colloidal kind of thing, then you re-inject it into the coronary artery in anterior wall MI in patients who are less than 6 hours history of chest pain, and this has been shown to reduce the infarct size. So if some of your examiner is interested in cardiology, he may ask you, when is it that you can give oxygen therapy in an alternative way? Okay, so this is something that we should know about oxygen. Rest, there was a phase in the management of acute MI, which was called a phase of masterly inactivity. In the times that, and Dr. Sodhi said, the myocardial infarctions were managed only with morphine, oxygen, and rest. Just rest, give aspirin, that's it. But now we have an active intervention. So rest is actually quite limited. Rest is limited, so the rehabilitation, the earliest phase of rehabilitation is also gone because we want the patients to be mobilized as soon or as early as possible. Aspirin. What aspirin do you give? Aap batao beta. What aspirin do you give in acute MI? What dose of aspirin and which aspirin tablet would you like to give? Any choices? So, okay, don't know. Okay, we should give soluble aspirin. What they say what we have been taught is buccal aspirin. The only aspirin which comes nearest to it in India is Disprin. So you give a full tablet of Disprin. Please ensure that in your casualty, in your emergency, you have a full tablet of Disprin available, which is to be given immediately. Disprin, by the way, is also the earliest treatment that any layperson can take. If you're asked to, comment on population, what treatment can a person safely take without causing any harm? आजकल बहुत चला हुआ है ना, ये किट ले लो, मैंने ये स्पेशल किट बना ली, इसमें 5 ड्रग्स हैं, इसमें 6 ड्रग्स हैं. The lowest hanging fruit, according to WHO, is only aspirin. So take a soluble aspirin. It knocks off your platelets in 15 minutes. It will not prevent the infarction that is going on, but the reinfarction and the expansion of the process is prevented. So aspirin, loading dose, 325 milligrams, soluble aspirin. After that, when you're giving it for a chronic therapy, it doesn't matter whether you give the good ecosprin that we all are familiar with, any coated aspirin or plain aspirin. There is no advantage of a coated aspirin. P2Y12 inhibitors. We have 3 P2Y12 inhibitors which are available now. Clopidogrel, we have ticagrelor, and we have prasugrel. So which one would you like to use? Clopidogrel. Okay. So why would we want to use clopidogrel? Probably because we have the most experience with it. At the present time, the default P2Y12, which should be given at the time of arrival, is ticagrelor. Okay. So you should give ticagrelor to these patients, 290 milligrams tablets, crushed and given. Why crushed and given? Because it has been seen that if you crush it and give it, the onset of action is earlier. Okay. Anticoagulants, you can use unfractionated heparin, you can use enoxaparin or low molecular weight heparins, you can use fondaparinum, and you can use pivalirudin. These are the 4 anticoagulants that are available. At the time of arrival, and even before the patient goes to cath lab, we must give these patients high dose of statins. What is high dose of statin? How do you define high dose of statin? Say that. The dose of statin which will cause at least a 50% fall in the level of LDL cholesterol is called as high dose statin. And which are the 2 statins which qualify for that? The 2 statins are a 40 milligrams of rosuvastatin or an 80 milligrams of atorvastatin, no other, and no lower dose. Okay. If I tell my students, if your teacher also doesn't know about it, doesn't matter, start it on your own. Okay. So use high dose of statin. What is the advantage? Number 1 advantage is that it decreases chances of acute kidney injury. The advantage on the day 1 at the time of arrival before sending the patient for PCI is it decreases contrast induced injury. So give high doses of statins. Beta blockers. Which beta blocker do you use? Metoprolol. Classically, the training has been to use metoprolol. Metoprolol, 50 milligrams twice a day or 25 milligrams twice a day to begin with, and up titrate the dose. Nonetheless, we also must remember that other than atenolol, the 2 other major beta blockers that can be used are bisoprolol and to some extent even carvedilol. People use. Don't use atenolol. It is no longer used. ACE inhibitors, you should always use ACE inhibitors, particularly if your patient has a third heart sound or crepitations. But in all patients, you should use ACE inhibitors on the very first day. Eplerenone, when should it be used? If your patient has clinical heart failure at the time of admission, the drug, the mineralocorticoid receptor antagonist, which has been tested as eplerenone. Eplerenone in the dose of 25 milligrams per day. Okay. Then rehabilitation, as I said, rehabilitation is actually now confined to those patients who have heart failure, at least the physical part of the rehabilitation. कि मैं कितना चल सकता हूँ, कब चल सकता हूँ. The rehabilitation now is more limited to managing hypertension, managing diabetes, emphasizing that you don't smoke, and your food habits. What diet will you take? Anti-ischemic therapy, nitrates we talked about. आप लोग कैसे nitrates देते हैं? Injectable nitrate देते हैं या sublingual nitrate देते हैं? Sublingual nitrate देते हैं. कौन सी sublingual nitrate देते हैं? Sorbitrate देते हैं या nitroglycerin देते हैं? Sorbitrate देते हैं. Well, that has an advantage of the ability to be given both sublingually and orally. But please remember, the oral nitrate to be used in acute coronary syndromes, if at all you use, is glycerol trinitrate. Even that is available. Glycerol trinitrate is again available in two forms. One form, which I would say the semi-quacks use, GTN 2.6 and 6.4. Those are useless therapies. Okay. In acute coronary syndromes, you use the conventional glycerol trinitrate tablet. It is available in 0.4 milligrams and it is also available in 0.5 milligrams. So both are available if you want to give nitrates, if your patient's pressure is high, but the most ideal way is to give nitroglycerin in the form of a drip. Okay. Then beta blockers we've already talked about. If your patient's PR interval is more than 240 milliseconds, do not use this. If your patient's heart rate at the time of presentation is less than 60, do not use it. Okay. Then calcium channel blockers, if beta blockers cannot be used, you use calcium channel blockers, or if your patient has a very high blood pressure. Morphine we've talked about, antiplatelets we have talked about. And so a few final slides. This is the ST elevation MI strategy and the non-ST elevation acute coronary syndrome strategy. So the first two parts are before the invasive, the reperfusion starts. So you determine the anticoagulation and you determine the antiplatelet therapy. As I said, give statins to these patients, give ACE inhibitors to these patients, and also give beta blockers to these patients. Okay, I can skip that. Another important thing is, what if my patient develops atrial fibrillation? What should be the therapy? If my patient develops atrial fibrillation, the most popular form of therapy is, or if my patient is a known case of atrial fibrillation and has now come with acute MI, for a very short period, say about 2 weeks or so, I give 3 drugs. And what are those 3 drugs? I give my patient aspirin, I give my patient clopidogrel, and I give my patient a NOAC, most preferably a apixaban, because that has been found to be the safest in terms of bleeding complication. I give aspirin for as short as 1 week, but ideally say up to 2 weeks. And then I take off the aspirin. I continue my patient on clopidogrel and apixaban for a period of 1 year, after which I take off the clopidogrel and only continue apixaban. This is if my patient has atrial fibrillation. All right. Okay. Another important thing is you can have these acute coronary syndromes with normal coronaries, what you call as INOCA or MINOCA, myocardial infarction with normal non-obstructive coronary artery disease. And there are a lot of causes listed here. One interesting cause that we must all remember is Takotsubo syndrome. Some amount of mental stress. It is also known as the sad heart syndrome, typically occurs in ladies. elderly ladies or middle-aged to elderly ladies, has a history of recent stress. My son died or my husband died, and she comes to you with typical chest pain. You find ECG changes. You think there can be ST elevation MI also. You do the coronary arteries and they are normal. You do the echocardiography, the ejection fraction is okay, but you do get certain regional wall motion abnormality. If you put a catheter in their left ventricle, it is like a takusubo. It's a Japanese bottle form of can used to catch the fish. So, but this is a reversible cardiomyopathy. So you can have reversible cardiomyopathies with normal coronary arteries. Okay. This is again something very important that I always ask my residents. What are the MI equivalents? So there are ECG patterns which are shown here: Wellens 1, Wellens type B, Wellens type A, a shark T pattern. This is knowledge is very easy to access these days. It is how you analyze it is more important. So you Google it, and in images you will get all these patterns. The important why I brought this is the only video that I'm going to show you. Look at this. This is a typical Wellens ECG, and this was about a 45 years old man. This is the only video I'm going to show you. You can see there is a proximal, very tight LED lesion, and in this patient, we do an angiogram and his artery starts to flow very well. This is the only video that I'm showing. But please remember, if a patient presents to you with MI equivalents, like Wellens, no need for any enzymes, no need for presence of chest pain. You have to send this patient for a coronary angioplasty. And my last slide is this. So depending upon how your patient presents to you, and what are the ECG changes, ST elevation or not, depending upon cardiac markers and depending upon the risk, your management will depend, accordingly. I'm sorry, I may have overshot on time, but then this I thought was a teaching session. Thank you so much.
Very excellent, informative, and we should talk at the level of Dr. Benson. Just one question, sir. Are you using IV antiplatelets and anticoagulation therapy?
Yes. See, IV antiplatelet is Cangrelor. That's a drug which is available. The company guys have been pressing us hard for 1 year, maybe more. They gave me actually a sample of Cangrelor and they said, please use it in an appropriate patient. I haven't been able to find an appropriate patient. In majority of the patients, if you give these patients a tablet of Disprin and crushed ticagrelor at arrival, majority of your patients are covered. It is very rare to find a patient who is in cardiogenic shock, has had an anterior wall MI, is persistently vomiting, has come within a few hours, and you feel that you need to take him immediately. You can't give him oral drug because he's been puking persistently. So there, Cangrelor is indicated. But we all as cardiologists know there are so many people show so many things. This was the reason I used Cangrelor. But classically, there are very, very few reasons.
So can a patient who has been loaded with the ticagrelor can be hospitalized?
Yeah. See, very good question. When somebody said we use clopidogrel, one of the reasons for using clopidogrel is if you're going to thrombolize the patient within the first 24 hours, the use of ticagrelor has not been tested. There was a trial called the TREAT trial, in which they saw that it was safe to give ticagrelor, but it was after 24 hours of thrombolysis. In terms of prasugrel, there is no evidence, but we all have seen patients who have been given without our knowing, and we have lysed them without any major problems. So if you ask me, is it unsafe? I would say no, it is not really unsafe. But if you say, is there any evidence? The evidence is only with ticagrelor after 24 hours. Prasugrel was never tested in medically managed patients.
So if the patient has come to a center where the primary PJ is not available, so the best drug to be loaded is the
It will be ticagrelor actually, unless you have an ST elevation MI and you want to thrombolize.
Thank you, sir. Very nice presentation and very informative, and we also learned very important things. Thank you.
Just to say a few words, thank you, sir. Thank you so much for giving such precious time and such a precious talk. Okay.
I'm a pharmacologist and I did experimentation over the dog. And my dog survived only because of the ACE inhibitor and the beta blocker.
Yes.
And it was a lifespan for 12 years and he survived for 15 years.
Yeah, human beings also survive if they are given ACE inhibitor.
And same thing was in the corona. So I request all the cardiologists and the medicine persons, they are real key to the society, that they must use the ACE inhibitor. Thank you very much.
Thank you, sir. Thank you, sir. It is just to announce that we are running a 2D Eco value-added course in our department by our own faculty, Dr. Amit Sharma sir, which is a 12 weeks, 3 months short course in which he has done a great job by teaching the faculty as well as the students, the postgraduate students. Today, on the behalf of this university, I would like to distribute these certificates who have done their value-added course in Subharti University. I would like to request Dr. Amit Sharma sir, along with Sandeep Bansal sir, to give the certificates to the students. Number one is our own faculty, Dr. Amit Alawat, who has done this 2D Eco course.
Next up is Dr. Pratish Kumar Mahanta, sir. Next up is Dr. Sanchit Bhandari. Next up is Dr. Bhumadya Jain. Lastly is Dr. Saurabh Singhal, sir. I myself has taken part in this. I would also like to say this course is open for externals also. Anybody from the students or from the faculty of any medical college or any field can come to join this course of ours. Thank you so much. On behalf of our entire audience, I want to express our appreciation for your time, expertise, and the passion you have demonstrated in addressing such a crucial topic. Your talk has undoubtedly left a lasting impact. So while you are still here, I would like to request you to kindly assist us in selecting a lucky draw. I will now request Dr. Saurabh Singhal sir to thank the speaker, Dr. Sandeep Kansal sir, with a memento and a bag.
Thank you, sir. Thank you. Yes, sir.
I would also request Saurabh Singhal sir to kindly present a memento of the conference to Dr. Bharat Gupta sir. Dr. Bharat Gupta sir. Next up is Dr. Amit Jain sir. Next up is Dr. Amit Sharma sir for the participation that has made the talk more meaningful and memorable. Dr. Amit Jain sir, while you are still here, I would like to request you to kindly assist us in selecting a lucky draw winner. Your participation will add an element of anticipation and joy to this moment.
Dhruv, Dr. Dhruv.
So he is also a postgraduate, first year postgraduate. Congratulations. No.
Without much ado, I would like to introduce our next set of chairpersons for our last talk of the day. These senior physicians are an eminent experts in the field of medicine who have graciously accepted our invitation to participate in this talk on autoimmune hepatitis. First up is Dr. P.K. Gupta sir. Dr. P.K. Gupta sir is the Professor of Medicine in Postgraduate Department of Medicine in Subharti Institute of Medical Sciences. He completed his MBBS from LLRM Medical College in 1981 and MD General Medicine from the same college in the year 1985. He is working in the field of gastroenterology and hepatology. He was awarded the Rashtriya Ratan Award in 2004 by the governor for his excellence in this field of medicine. He has published several papers in national as well as international journals. He is a lifetime member of various medical societies and has served as various positions in IMA and API. He has organized various state level programs in IMA. Next up, I would like to request the honor of Dr. Sandeep Jain sir to serve as the chairperson. Dr. Sandeep Jain sir did his MBBS from LLRM Medical College, MD from LLRM Medical College. He is certified with FCCS course by the California, USA. He did an ACLS course from the American Heart Association. He has presented various papers in national and as well as international conferences. He has been awarded as the American College of Physicians. He is the best IMA secretary UP State 2019. He has several social awards for the best medical services. Currently, sir is practicing as a consultant physician at Begum Bridge, Meerut for the last 26 years.
Sir is also at present IMA President Meerut. I would like to warmly welcome Dr. Sandeep sir to be here.
Next up, I would like to request Dr. TVS Arya sir to come up, please. Dr. TVS Arya sir has been working as managing medical emergencies and fostering positive relationships with patients and their families. He is a lifetime member of various medical societies. He has been awarded Meerut Ratan and several other awards for his relentless work saving lives in COVID practicing consultant physicians. He has over 30 plus years of experience in merit. Lastly, I would like to request Dr. Dhruvkant Mishra sir to kindly come forward. Dr. Dhruvkant Mishra sir, he is an alumnus of Netaji Subhash Chandra Bose Medical College, Subharti Medical College, 2014 batch. He was awarded as the gold medal for the best outgoing PG in the Department of Medicine. He was the previous assistant professor in the Department of Medicine at Subharti Medical College, Meerut. He is currently a consultant in the Department of Gastroenterology, Hepatology and Liver Transplant at Indraprastha Apollo Hospital, New Delhi. He specializes in therapeutic endoscopy, IBD and metabolic liver diseases. He is a member of the Accreditation Society and the Joint Commission International. He has multiple publications in national as well as international journals.
A special mention from my side, he is my favorite student. I have taught him. I have also gained his interest in endoscopies. So he loved endoscopy so much that he is doing endoscopy as a DM gastroenterologist. Thank you so much.
I would request Dr. Sandeep Jain sir to kindly introduce our next chairman, next speaker.
It's a pleasure to introduce our speaker today, Dr. Professor Manish Kumar. He is MBBS from King George Medical College, Lucknow University in 1993, and MD Medicine from Bhatnagar Medical College, Allahabad University in 1998. Was experience is Professor Medicine Department, ABVINS, RML Hospital, New Delhi. Joined CHS on 9th October 2003 as medical specialist, working experience in various VIP units, ex-Prime Minister, cell rotational duties as physician, worked for 17 hours there, Prime Minister's cell situation in RML Hospital for another ex-Prime Minister since 2024. Prime Minister House rotation duties as physician and also worked VIP under Prime Minister of India since 2007. Vice President House rotation duties has also experience of working Honorary President of India for the last 3 months in year 2021 and multiple publications in national and international journals. So I feel you are a very knowledgeable speaker with us and welcome with a round of applause.
Thank you, chairpersons, for giving a brief introduction. And at the outset, I am thankful to Subharti University and Dr. Saurabh for inviting me and giving me this opportunity to speak on this topic, autoimmune hepatitis. And this is a quite uncommon topic for a PG student because most of the time they are busy in cardiology, neurology, and respiratory. Gastro comes in the last priority for a PG student, but in practice, this is just opposite. In practice, a lot of patients are from gastro. So they must be aware of the common things which they will face in the future. And as we are running late and I am placed between you and lunch, so I will try to be as quick as possible and complete my talk within 20 minutes. So my topic is autoimmune hepatitis diagnosis and its management. So I will cover my topic in these headings. First of all, historical aspects, then epidemiology, clinical presentation, pathogenesis, histology, role of imaging, treatment, and a brief mention of a special population. So a few facts of this disease, historical fact. This disease was first diagnosed in 1950 by a Swedish physician, and he diagnosed this syndrome in a young female who presented with jaundice, weakness, fatigue, and amenorrhea. And he labeled this as a case of some autoimmune related injury to the liver. After 6 years, a immunologist from Australia, Maclay, he coined the term leukoid hepatitis, and after that, the name was changed to autoimmune hepatitis. This is a immune-mediated injury to the liver, and it is characterized by specific circulating antibodies, increase in the IgG level, and distinct histopathological findings. It happens because of the molecular mimicry to the hepatocytes, and this is one of the reversible cause of CLD when it is treated on time. So some few things about the epidemiology. The global annual incidence is 1.37 per 1 lakh population, and global annual prevalence is 17.44 per 1 lakh population. So this is slightly, or you can say 3-4 times more common in female than male. Out of 17, approximate 17%, around 15% are male and 2% are 15 are female and 2% are male. And it varies from the various regions of the world. In Asian, the incidence is 1.31. In European, it is 1.37. In American, it is 1%. And the prevalence is also changes according to the region. But I like to say that this incidence and prevalence is on the rise because more and more physicians are now aware, and incidence and prevalence depends upon the sensitization of physician and the way they are choosing to diagnose the antibody level, which technique they are using to detect them depends. If they are not using correct method, then results come out to be negative, and it shows a false belief that this disease is not very common. So about the clinical presentation, this happens in the 2nd to 6th decade, although it can happen at any time of the life, but the most common is in the 2nd to 6th decade, and the peak incidence is in the around 45 years of the age, and 3/4 of cases are women, and they have 3 patterns of clinical presentation: acute onset, insidious onset, and asymptomatic onset. We will discuss one by one. Acute onset autoimmune hepatitis. In this case, AST and ALT are at least 5 to 10 times of the upper limit, and it presents with jaundice and deranged PT and INR. A small number of the patient can also present with acute severe hepatitis and subfulminant hepatitis, which can progress to liver failure. Sometimes it may be difficult to distinguish it from the acute viral hepatitis. In such condition, biopsy is necessary to look for the evidence of fibrosis. You see, whenever the patient comes to the first time with the deranged functions, LFTs, it can be anything, acute viral, or it may be because of autoimmune. But if your viral markers are doubtful, so to be 100% sure, you can do biopsy, and if biopsy is showing fibrosis, it favor more so autoimmune hepatitis, because in acute viral hepatitis, plain acute viral fibrosis will be either absent or negligible. In insidious onset, this present with the specific symptoms like fatigue, arthralgia, malaise, amenorrhea. In small proportion of cases, sign and symptom of hepatic cirrhosis may be present. Asymptomatic onset patient does not present with liver sign and symptom of liver disease. It is incidentally detected with abnormal LFTs, sometimes detected when patients are being evaluated for other extrahepatic autoimmune disorder like thyroid, celiac disease, and rheumatological conditions. Because these autoimmune diseases, they have a common origin. So patients of thyroid on investigation found to have deranged LFT. So you may think of liver involvement, autoimmune. So something about pathogenesis of this entity. This is interplay of these 3 things: genetic and epigenetics, and abnormal immune regulatory response, and environmental triggers. HLA alleles like DR3 and DR4 have been implicated as etiopathogenesis of autoimmune hepatitis, and epigenetics factor that alter the gene expression without changing the nucleotide sequence may also contribute to the clinical expression and phenotype of the disease. Multiple hypomethylation genes have been described in the CD4 positive and CD19 positive T lymphocyte of patients with autoimmune hepatitis, and circulating micro-ribonucleic acid 21 and 22 correlates with the laboratory and histological finding of liver inflammation. And the role of autoimmune dysregulation, a number of regulatory T cells are reduced and their liver function is function is impaired, a scenario in which cytotoxic cells such as Th17 are let loose to initiate and perpetuate liver injury without proper control. The intrahepatic environment seems to be particularly skewed towards the pro-inflammatory milieu that favors recruitment and activation of inflammatory and potentially autoreactive T cells, whereas the regulatory component of the immune system is largely kept silent. And these are the environmental triggers, like molecular memory based on the base mechanisms is proposed, and common viral infections like hepatitis, measles, cytomegalo, Epstein-Barr virus, several drugs like nitrofurantoin and minocycline, herbal medication, and vaccines. COVID-19 vaccines there are cases, COVID-19 vaccine also induce incidence of deranged liver function because of pathogenesis. COVID virus attached to the cholangiocytes, and it triggers the autoimmune reactions. There is new in the recent state-of-art review published in BMJ. They have given this new entity, abnormal gut liver abscess, role of abnormal gut liver abscess in the pathogenesis of autoimmune liver disease. There is a rise of few cytotoxic microbiomes, and there is fall of few cytoprotective microbiomes in patients of autoimmune hepatitis. And in addition, the oral microbiomes is significantly different in autoimmune hepatitis, with enrichment of streptococci and varionella and leptotrichia. And if this hypothesis is supposed production by antibodies and ANA and SMA, LKM1, and soluble liver antigen and liver pancreas antibody. If they are found positive, then consider autoimmune hepatitis. And if these are negative, then and if there is a strong suspicion, then you can repeat these antibodies after some time, and they may come to be positive. So there is a scoring system for diagnosis of autoimmune hepatitis. This was given by International Autoimmune Hepatitis Group. This is the old scoring system, which was slightly cumbersome, having lot of factors, and it involves pre-treatment and post-treatment scoring also. So now this is almost taken off, and now they have suggested very simplified score. This is the simplified criteria which is under current practice. It involves 4 factors: antibodies, level of autoimmune hepatitis associated antibodies, IgG level, viral hepatitis, and liver histology. So these are the 4 factors, and these are the scoring. If ANA is more than 1:40 ratio, point is 1. If it is strongly positive, 1:180, point is 2. Like if IgG is more than upper level, it is 1. More than 1.1 level is 2. If liver histology is compatible, it is 1. If it is typical, it is 2. And viral hepatitis, if it is absent, this is 2. So out of these points, if the score is 6, then autoimmune hepatitis is probable, and if it is 7 or more than 7, then it is definite. So these are the 4 variables in the simplified score: antibodies, IgG level, viral hepatitis, and liver histology. Definite autoimmune hepatitis if it is more than or equal to 7, and probable if it is equal to 6. This is the way, this is the method of detecting. So I am skipping this because of time, shortage of time. So how the autoimmune hepatitis is divided into 2 types, type 1 and type 2. Type 1 is characterized by presence of anti-nuclear antibody and anti-smooth muscle antibody. And type 2 is characterized by presence of anti-LKM body and anti-cytosol antibody, anti-liver cytosol type. Approximately 15 to 20% of the all patients with autoimmune hepatitis are positive for anti-soluble liver antigen and liver pancreas antibody, and they are characterized by highly specific and low sensitivity for autoimmune hepatitis. Now comes the histology. If your patient is not fitting as per the simplified scoring system, is not coming into the reaching to the level of 6 or 7, then patient is subjected for histology, which will add further points to confirm the diagnosis of autoimmune hepatitis. To define histology as typical of autoimmune hepatitis, the International Autoimmune Hepatitis Group simplified criteria requires 2 of the 3 following features in histology. Number 1 is interface hepatitis, number 2 is rosette formation, and number 3 is empyreopolosis. So this is the new term for PGs, and even for some of the faculty not dealing with the hepatology. Empyreopolosis is a process in which lymphocytes are invaginate inside the hepatocytes. So this is almost characteristically seen, although this is not pathognomic, but it is characteristically seen in cases of autoimmune hepatitis. So interface hepatitis is the histological hallmark of autoimmune hepatitis. In this recent review article published in BMJ in 2023, they have slightly changed the nomenclature. In the simplified score, it is either typical or atypical, but they have given likely autoimmune hepatitis and possible autoimmune hepatitis and unlikely autoimmune hepatitis. But these terminologies are just in the recently given, and they are more confusing. So it is not. It is better to stick to our previous criteria given in simplified score. Now, something about role of imaging in the diagnosis of autoimmune hepatitis. Autoimmune imaging has so far played a limited role in the diagnosis of autoimmune hepatitis, and role is only limited to confirm the signs of cirrhosis and hepatocellular carcinoma. Now, this is the new thing: virtual liver biopsy. Multiparametric MRI can generate quantitative information of clinical utility as a non-invasive tool for diagnosis of liver disease. And iron-corrected T1 is the reliable multiparametric MRI measurement of fibroinflammatory activity predictive of clinical outcome with low inter-observer variability and good correlation with liver histology. But this thing is still under the research purpose and not used routinely. And even if it is used, it is in conjunct with the other findings. It is not considered as singly as a confirmatory marker of the diagnosis. Now there is a dilemma of distinguishing autoimmune hepatitis from drug-induced liver injury. So sometimes severe acute autoimmune hepatitis can mimic drug-induced liver injury on histology. The presence of significant fibrosis is a clue towards the autoimmune hepatitis, because drug-induced liver injury will always be of acute onset, relatively acute onset, and fibrosis takes time to develop. So we in our ward, we have a patient. We have experienced this condition. The patient was on dapsone and he developed deranged liver function, and then he had raised IgG level also. So we were suspecting it is autoimmune hepatitis. We did biopsy, but biopsy was suggestive of features of drug-induced liver injury. Then we reviewed the literature, and it is confirmed that sometimes severe acute autoimmune hepatitis may mimic drug-induced liver injury. Drug-induced liver injury is characterized on histology by the injury to bile ducts and ductopenia on histology. So then after biopsy, we stopped the drugs and we tapered the steroids. But very soon, this patient again developed a rise in the enzymes. So this was confirmatory that this is not a drug-induced liver injury, because we have stopped the drug. Even then, the enzymes are rising. And when we restarted steroid, then enzymes started settling down. So this is the chart, very simplified chart, very easy to follow. Whenever you confirm a case of autoimmune hepatitis, you start with steroids and azathioprine. These are the two corner drugs for the management of autoimmune hepatitis. And on week 1, we start steroid at a dose of 1 milligram per kg body weight, 60 milligram. Next week, we taper to 50 milligram. Third week, 40 milligram. And at that time, you add azathioprine. Next week, 30 milligram. And when you reach 25, you double the dose of azathioprine, then 20 milligram, and keep on reducing the dose of prednisolone and maintain the disease control with azathioprine. So this is the treatment algorithm. This is a slightly busy slide, and we are also getting late. So these steroid and azathioprine, these are the two main drugs for the treatment. And if there is a response,
patient, you start according to the previous chart and patient is showing response, this is autoimmune hepatitis. But if there is insufficient response, it's because of the resistance to azathioprine, and this can be overcome by adding allopurinol. This is mainly because of these two metabolites, 6-metacaptopurine and 6-thioguanine. So we can check the level of these two metabolites, and if this is less than 220, then we can add allopurinol and it will improve the effect. So we can divide our treatment protocol into two: induction of the remission and maintenance. For the induction of remission, the first aim is this is the first aim of the treatment, and sometimes it takes around approximately 6 months to achieve the induction, and steroid is the main drug of choice for induction. And few journals, few societies have advocated lower dose, 0.5 milligram per kg body weight. Also, if the disease, autoimmune hepatitis severity is not very severe. And role of, as I have told you, role of azathioprine is for the maintenance, because you cannot keep on giving steroid for longer time, and the treatment for autoimmune hepatitis is sometime lifelong. So you have to switch over to the azathioprine for maintenance. In maintenance, azathioprine is given in 1 to 2 milligram per kg per day as a monotherapy or with combination with steroids. If patient is intolerant to azathioprine, then we can switch to mycophenolate mofetil. Duration of treatment is usually lifelong, and you keep the patient under monitoring, and the art is to at what dose of steroid and at what dose of azathioprine you can achieve biochemical resolution in the form of normalization of enzymes and normalization of IgG concentration. Now a brief mention about the special population in autoimmune hepatitis in elderly and children. In elderly group, this disease is more benign and there is high rate of complete response, and there is overall better prognosis. And in children, the disease is usually seen as having more aggressive course. And pregnancy and autoimmune hepatitis, there are the main things. The pregnancy is generally considered as an immunosuppressive state, but it is seen that autoimmune hepatitis may flare up during pregnancy, and it is having a harmful effect both for fetus and mother. And there are 2 points in the course of pregnancy where it shows flare. One is just after the delivery, postpartum period. There is a sudden rise in the disease activity, and second peak is at the time of the stopping this medication. So during this time, there is a need to step up the therapy. These are the emerging concepts. So a brief mention about overlap syndrome. There is a sometime confusion. Either this is a purely autoimmune hepatitis, or there is overlap of primary biliary cholangitis or primary sclerosing cholangitis. So if you have suspicion, then you can confirm primary biliary cholangitis by the Paris criteria. To confirm PBC, you should have 2 out of 3. One is serum alkaline phosphatase more than 2 times, and anti-mycophenolate mitochondrial antibody positivity, and fluorid duct lesion on histology. If two of these are present, then this is PBC, and if it is associated with other histological features like interface hepatitis or rosette formation or imperiopullosis, then you can label this as a overlap with the primary biliary cholangitis. And for another group is primary sclerosing cholangitis. This is suspected when there is a typical feature of autoimmune hepatitis, absence of antimitochondrial antibody, and on MRCP there is evidence of large duct primary sclerosing cholangitis and evidence of small duct sclerosing cholangitis on liver histology. On MRCP there is large duct. On histology, if there is these lesions, then you can label this as a overlap of primary sclerosing cholangitis with autoimmune hepatitis. So as for any chronic hepatitis, there is a risk of hepatocellular carcinoma in autoimmune hepatitis also, which is a known complication of liver cirrhosis. So these are a few, till now there are only two standard drug, steroids and happening, but now biologics are coming up in the large way, so they are tried in autoimmune hepatitis also, and there is a definite role of anti-B cell rituximab and anti-TNF alpha infliximab in management of autoimmune hepatitis. So this is the summary of recent changes in the disease perspective. There is a new concept of abnormal liver-gut axis in the pathogenesis of autoimmune hepatitis, and the complex and cumbersome old criteria has given way to the simplified criteria for the diagnosis of autoimmune hepatitis. And liver histology is now suggested as likely, probable, and unlikely. And this is the new thing: virtual liver biopsy using multiparametric MRI, an emerging diagnostic modality, and emerging and targeted therapies like anti-B cells and anti-TNF cells. These are the new development in the management of autoimmune hepatitis. These are the references, and thank you. I will like to answer any question and queries.
Thank you, Professor Manish Kumar, for a very initiative yet simplified approach to management and diagnosis of acute immune.
Thank you.
Autoimmune hepatitis. Yeah, we still have to go a long way because we do not have any space to therapy. I would like the PGs from other institutions also to make their presence felt. Yes, any questions from PGs other than Subharti? Others are also there, but they have not made their presence felt. Bolo bhai, some questions from LLRM, from Muzaffarnagar? No?
So I think either the topic is clear or it has gone above the head. So I will again summarize the simplified approach for a physician angle. Whenever a patient of any abnormal liver function test will come, you will. Yes, please, yes.
Although the patient who has come with the increased transaminases, and we see the presentation of a patient of autoimmune hepatitis is very vague. So if the patient has come with a vague presentation of jaundice, those are related to features, and how to suspect and then how to proceed.
That only thing I was telling to, yes.
Because this is mostly by exclusion only. We don't have any specific point.
Whenever a patient of any deranged liver function test comes to your OPD, you should do stepwise approach. First, rule out common things. First, you rule out viral hepatitis. Patient may be having, you do hepatitis B, C, and if it is found negative, then you do for the other chronic liver disease like Wilson's and for hemochromatosis. And if it is again come negative, then you see for diabetes to rule out NASH. And even if all the things are negative and patient is having deranged LFT, then you think of autoimmune hepatitis. Autoimmune hepatitis, the moment you conclude that it may be a case of autoimmune hepatitis, you investigate and order for IgG level. If IgG levels are high, then you, and viral markers are already negative, then you have already 2 points in favor. 2 points are lacking: autoimmune antibodies and histology. So then next step, you order for autoimmune hepatitis profile, anti-nuclear antibody, anti-LKM, and liver cytosol or liver pancreas antibody. So if they are positive, you are approximately close. But if these are negative, then you opt for biopsy, liver biopsy. Then liver biopsy will give you the diagnosis. If it is showing interphase hepatitis, rosette formation, and very characteristic is emperiopullosis. Emperiopullosis, this is the question asked in the DM entrance examination. What is the characteristic finding of autoimmune hepatitis? So this is how you approach the case of you suspect and you proceed a patient with a deranged LFT.
Very difficult. As you have said, a patient with deranged liver function, you have to exclude viral markers, number one.
Yes.
Number two, then you will exclude the chronic disease like Wilson disease or hemochromatosis and others. And these are all excluded. Then you go for IgG level.
Yes.
IgG level and then autoimmune antibodies. So autoimmune antibodies are there, AMA, etc. Others also. They may be positive, may be negative. If they are positive, well, you can suspect that the patient is having autoimmune hepatitis. But if they are negative, then it is difficult because then you are leading to a disease for which you have to be steroid or agent therapy for the lifelong. And biopsy of liver is not that easy because with the patient and we have complication of biopsy.
No. This is we are.
Biopsy of liver is not that easy. At least we are not that habitual of doing.
So for a routine setup, it may, I agree that it is slightly risky. But if you are strongly suspecting, you can send the patient to the center where liver biopsies is done. I am doing a thesis work. I have given this thesis on autoimmune hepatitis to my PGs, and we have done around 40 liver biopsies, and out of 40, around 20 are positive for autoimmune hepatitis, and there is no complication. So it is a matter of doing the things. And
so the message becomes that if these autoantibodies are negative, IgG levels are high, and you have excluded other things, then the only option left is liver biopsy.
One option is a liver biopsy, or you can wait and repeat these antibodies after some time.
Because imaging studies are not possible.
Yes, you can repeat antibodies after some time, and sometimes they are in our patient also. ANA is found to be positive, but positivity of antibodies are very less in numbers, because it depends upon the what technique you are using. As I have told you, incidence and prevalence depends upon the sensitization of physician and the method of checking the antibodies, which method you are using. So there are specified method and laboratories which are familiar of dealing with such kind of antibodies are giving better results than the general laboratories.
Another thing, if IgG levels are high and autoantibodies are positive, then we can exclude or we can omit this liver biopsy.
Yes. If your score is more than 7, then you can start.
Okay. Liver biopsy is not required.
Not required.
And experience about any case like we have certain refractory case of autoimmune hepatitis, and they are not responding to steroids. So at what level would you like to start with the active cell activating factors and belimumab and they are the very good drugs in that case.
I have given you in the slide that there is a criteria of measuring the biological response, biochemical response. If the enzymes are settled down to the normal and IgG level are settling down to the normal, enzymes more than 50% and IgG is towards the normal, then the patient is showing response. But if it is not showing response, then after you should wait for 6 months. Sometimes it takes 6 months to respond. After that, you can label them patient is resistant, and one of the reason is intolerance or difficulty in the action of azathioprine. So second step, you can add allopurinol. And even if that is not working, then you can switch on to the biologics.
So what is your policy and experience in using steroids in patients with decompensated liver disease, steroids and other therapies?
Yes, this is a nice question, and because all the treatment are valid for the compensated cirrhosis. For the decompensated cirrhosis, there is a study done in India by 2-3 institutes, and they have found that there is no benefit of treatment in patient of decompensated cirrhosis. So the outcome is similar whether you treat or whether you not treat in decompensated cirrhosis, because they are already burned out. So there is hardly any scope for treatment in decompensated.
Thank you very much once again, Professor Manish Kumarji. I hope all of you must have enjoyed it, and I have also learned certain things. Thank you very much.
Thank you.
I extend my sincere gratitude on behalf of SUMECON for your outstanding contribution as a speaker on autoimmune hepatitis. Your ability to communicate complex medical information in a clear and engaging manner greatly resonated with our audience. I would now request Dr. Saurabh Singhal sir to kindly come forward to thank the speaker, Dr. Manish Kumar sir, with a memento and a bag. Bag. I would also like to thank the chairpersons of this talk, that is Dr. TVS Arya sir. Dr. PK Gupta sir. Dr. Sandeep Jain sir. And Dr. Dhruv Khan Mishra sir for their attendance and wholehearted participation. Lastly, I would like to invite Dr. Saurabh Singhal sir to deliver the vote of thanks, expressing gratitude to our participants, sponsors, and everyone present involved in making this event a success.
So good afternoon, everyone. From good morning now to good afternoon. So I stand again before you with a heart full of gratitude as we come to the end of today's talk of SUMECON. The workshops are still pending in the paper and posters. Tomorrow morning, we will be having it in the department. The cardiology workshop, that is a 2D eco hands-on workshop, will start just after the lunch in the Department of Cardiology, Subharti Medical College. Those who have registered for that can gather in the cardiology department after the lunch. First and the foremost, I extend my deepest appreciation to our distinguished speakers. Your expertise and willingness to share your knowledge has been the cornerstone of today's success. Your insights have not only enriched our outstanding, but also sparked new ideas and avenues for exploration. I would also like to express my gratitude to the organizing committee and volunteers who have worked tirelessly behind the scenes. No special mention of Dr. Sumit, Dr. Amit, Dr. V.D. Verma sir, Dr. Karthik Rajpal, and my whole team. To our participants and attendees, thank you for your active engagement and thoughtful contributions. Your presence has added immense value to the discussions, and we hope you leave here today with new perspectives and connections. Last but certainly not the least, I thank Atul Krishna sir for his continuous support and guidance. His vision and leadership have been an instrumental in shaping the success of today's event. As we conclude, I would like to invite all the dignitaries, speakers, chairpersons to join us for the lunch. We will resume today after the lunch in the Department of Cardiology. Thank you once again. And I would also like to thank all the PGs, those who have come from their colleges, from their own cities here for this talk. Thank you so much. Thank you.
Thank you, sir, for your thoughtful words that will undoubtedly resonate with the audience and provide a fitting conclusion to the event. I am confident that your presence will inspire and motivate everyone present. As we draw the curtains on this enlightening medical conference, I am filled with gratitude and appreciation for the collective spirit of learning and collaboration has permeated the event today. Our sincere thanks go to each one of you, the distinguished speakers, dedicated organizers, and the attendees for making this event a resonating success. The exchange of knowledge and experience has been invaluable. I am also delighted to extend an invitation to all the delegates and faculty for the upcoming 2D echocardiography workshop headed by Dr. Amit Sharma and Dr. Deepak Baisia, sir, where will we delve into the latest advances and best practices in cardiac imaging. As we part ways, please accept our deepest appreciation for your active participation and contribution. May the knowledge gained here inspire your future endeavors, and may our paths cross again in the pursuit of excellence in medical healthcare. Thank you for being a patient audience. I invite you for a delightful lunch. See you next year with a bigger and a better version of SUMECON. This is your host, Karthik Rajpal, signing off. Thank you.